Yo mas, ini mas, kita nyala, pero pergi. Api kok. Kafe. Pas cukup padahal yang CPT ya.
PhD Department of Dietetics Faculty of Medicine and Health Science, University Putra, Malaysia. Cecilia Akinjide, Health Information Educator, Digital Health Advocate Britannia Raya. Miss Catherine Carp, Research and Innovation Lead for Women's Health at King's College Hospital, London. Professor Dr. Asha Tapa from Nepal. And all lecturers, students, and participants and invited guests who are attending this international conference. Before starting the event, allow us to introduce ourselves as the Master of Ceremony. I am Hanifa and my partner, Novelin. First, we are going to follow a series of presentation from the honorable speakers. Then we will have the oral and poster on the second day. To begin our session, we are honored to welcome our first speaker, who will discuss practical approaches to identify most musculus in patients with advanced CKD, an issue that remains highly relevant in clinical and community setting. The speaker will deliver the topic Closing the Gap, Practical Tools for Detecting Muscle Loss in Advancing Chronic Kidney Disease. Without any further ado, allow us to invite the first speaker for today's event, Honorable Speaker, Associate Professor Zulfitri Daud, PhD, RD, Department of Dietetic Faculty of Medicine and Health Science, University Putra, Malaysia. This session will be accompanied by Dr. Henny Hendriani, SKM MPH, as the moderator. Dr. Henny, time is yours. Good morning, Dr. Henny Hendriani. Can you hear my voice?
Yes.
Excuse me, Dr. Henny. Okay. Thank you, Dr. Henny, for joining us this morning.
Okay, I still mute. I cannot speak. Okay, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Thank you very much, MC, for giving me the time to guide this presentation session. Distinguished speaker, guests, ladies and gentlemen. First of all, I would like to welcome you all to today's international online seminar. I'm Dr. Henny Hendriani from Nutrition Department, Polytechnic of Health Semarang. Before the presentation begins, allow me to introduce the speakers. Today we have Dr. Zulfitri Azwan Matdaud, PhD, RD, Associate Professor from Department of Dietetic, Faculty of Medicine and Health Sciences, University Putra Malaysia. Good morning, Dr. Zulfitri.
Good morning, Dr. Henny.
It's nice to see you again. Yes. Thank you, Dr. Zulfitri, for joining virtual with us today. Before the presentation begin, let me read the bibliography or CV of Dr. Zulfitri. Associate Professor Dr. Zulfitri Azwan Matdaud worked in Department of Dietetic, Faculty of Medicine and Health Science, University Putra Malaysia in Selangor, and the education background from Bachelor of Health Science, University Sains Malaysia, and Master of Health Science, University Kebangsaan Malaysia, Master of Science, Nutrition and Food Science, Wayne State University, USA, Doctor of Philosophy, Nutrition and Food Science, Wayne State University also. And then not only education, Dr. Zulfitri also have many training for registered dietitian nutritionist, registration Commission of Dietetic Registration USA, and then registered dietitian from Malaysian Allied Health Profession Council, and also ISAC Level 2 Certified Anthropometrist from International Society for Advancement of Kinanthropometry. Okay, and then capacity development, and also Dr. Zulfitri always or occasionally have a lecturer in several universities such as Universitas Gadjah Mada, Yogyakarta, and also in Malaysia, of course. Maybe that's for the CV of Dr. Zulfitri. Now, maybe we have to welcome Dr. Zulfitri, who he will give about 45 minutes presentation, and the rest 15 minutes for discussion with the topic Closing the Gap, Practical Tool for Detecting Muscle Loss in Advanced CKD. Dr. Zulfitri, the time is yours.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. Yeah. Um, Thank you, Dr. Henny, yeah, for your kind introduction. I will share my slide in a bit. Yeah. All right. Can you see my slide?
Yes,
Okay.
it's clear.
Okay. Um, so very good morning, everyone. And I would like to also congratulate to the organizing committee from Poltekkes Semarang for organizing this amazing conference, 8th International Conference on Handling of Non-Communicable Diseases. So I've seen a lot of speakers from various countries, and also, very useful or very interesting topics that have been lined up. Okay, so from the nutrition perspective, we are I'm going to talk about what are the tools that we can use, yeah, to detect muscle loss in advanced chronic kidney disease population, right? Before I proceed, just a little bit of disclosure that I have nothing to disclose or conflict of interest pertaining to this presentation. So in the next 45 minutes, what I'm going to do is we are going to discuss a little bit about malnutrition in general, and then focus basically on protein energy wasting. Yeah, what are the term protein energy wasting and how it differs with malnutrition. And then we're going to zoom in a bit on why understanding or assessing protein energy wasting does matter to your population. and how we can screen and diagnose of protein energy wasting, if there's any standard that we need to follow in, and also what we could do, just a little bit of description, what we could do to address protein energy wasting. And if we have time, we can go over some case sharing and some take-home messages. All right. So before I begin, perhaps if some of you working with this kind of population and you are interested to look over on the credible guidelines for this particular population, you can refer to Nutrition Guideline for CKD that was published in American Journal of Kidney Disease by KDOKI. KDOKI stands for Kidney Disease Outcome and Quality Initiative. This was published in 2020. But bear in mind that the literature from this particular, you know, literature was actually derived all the way until 2016 only. So from 2016 to now 2025, so we are having a gap of literature. Yeah. In Indonesia, you have a guideline by per Perhimpunan Perhimpunan Nephrologists Indonesia, but I'm not sure whether it has been updated to the current guideline. Okay, so there are also some other guideline that you can refer to, especially if your CKD patient, chronic kidney disease patient, were hospitalized. Yeah, so this is can come from the Aspen guideline. And latest guideline, some component of nutrition were actually outlined by this guideline was from KDIGO guideline, which was published in 2024. So these are some of the guidelines that you want to look, you want to read further in order for you to manage a chronic kidney disease population in your particular setting. All right. Let's zoom in into our main focus today, understanding what is protein energy wasting, or in simple term, I just call it PEW, yeah, PEW, and then versus malnutrition. What does it mean? So ladies and gentlemen, when we talk about malnutrition, yeah, malnutrition is having a such a huge perspective. You can talk from a chronic energy deficiency in the case of on this, if you can see from the slide right now, is on your left hand side. This is a chronic energy deficiency, yeah, in which patient have more physical symptom as they have a decline in their BMI. Yeah, so this could be due to the health problem, secondary to health problem, secondary to diseases, or due to the organic cases in which inadequate of nutrition, inadequate of intake, all of these lead to chronic energy deficiency. On the other side of the spectrum, we can have excessive energy intake, which could be due to the sedentary intake, yeah, and lead to various metabolic conditions such as cardiovascular disease, diabetes, and also increased risk of certain other cancers and so on. Yeah. So the spectrum of malnutrition is huge, but of course, in most literature, when we say malnutrition, is mostly referring to this the other side, which is a chronic energy deficiency situation. So what are the different and malnutrition that we are talking about in chronic energy deficiency versus malnutrition that we are seeing particularly in advanced chronic kidney disease population? So let's zoom in into the generic malnutrition that we are seeing in all kind of patient. Yeah. So basically, if you can define this malnutrition, is basically due to the nutrient intake or due to the poor absorption or absorption deficiency, in which leading to the altered the body composition of our clients or our patient. And in all clinical condition, we can see this can exist. It increase in terms of prevalence among elderly. Yeah. So what are the drivers? What actually cause malnutrition? So this is mainly due to the organic cases such as poor intake, low accessibility to food. All of these can cause drivers that can cause malnutrition in this particular population. But the specific situation in which inflammation is not necessarily present in these organic cases of malnutrition. But there are metabolic stress that could happen or that could present. Yeah. And how do we then, as a dietitian, as a nutritionist, how do we then diagnose whether this specific population has malnutrition? We can use GLIM. Yeah, if I'm sure that if you are a nutritionist or dietitian, you are aware about GLIM. And then SGA is subjective global assessment that is being typically used as well. Yeah. So the treatment is simple. Basically, you improve the intake, you provide the supplements, you make sure the accessibility of food is there. All right. So you have to improve the intake in order to improve the malnutrition for general population. But for CKD population, the specific term that is being coined for this particular population is known as protein energy wasting or PEW. Yeah. This is particularly very specific for CKD and in some other organ failure as well. What are the other organ failure? These include end stage, liver disease, and so on. Yeah. So, what are the syndrome that we are seeing in this particular population? They basically loss of body protein and energy store. And on top of that, they also exhibit metabolic derangement. What do we mean by metabolic derangement? They could subsequently have metabolic acidosis and some other metabolic condition. Yeah. And the population are very specific for CKD population. That's why we call this as PEW. Yeah. And what are the drivers to this protein energy wasting? Unlike other population in which due to accessibility of food, due to inadequate amount of intake, yeah. But in this particular population, it's not necessarily due to inadequate amount of intake, but there are some other component contributing to it, such as uremic toxin, yeah. The dialysis treatment itself, triggers some nutrient loss, such as some amino acid loss and so on. And the treatment itself also triggers chronic inflammation. So the chronic inflammation, chronic and persistent inflammation is the hallmark that you want to look at, yeah, for this particular population. And there are some hormonal imbalance, yeah. And this particular population will have persistent low-grade inflammation. And in terms of metabolic stress, you could see they have higher protein catabolism and also experience insulin resistance. So there are specific tool that we can use in order to diagnose protein energy wasting or PEW in this particular CKD population, which is using ISRNM criteria, in which I'm going to show to you a bit later. Yeah. Then how to improve then? If in malnutrition cases, we just give a nutrient for them. We just give additional supplements. We just give, make sure they have adequate amount of food. But in this particular patient, PU patient, so we need a multimodal approach in which we have to treat the underlying causes, which is the inflammation per se. We have to look at the clinical factors, the dialysis factors. We have to correct on that as well. On top of that, of course, nutrition exercise will also help to treat this particular population. Okay, let's zoom in into a more detailed pathophysiology, how people with advanced CKD develop PEW or protein energy wasting in the first place. So this was published by our group. Sativa and all was my PhD students. Um, so we outlined there are two components if that can actually trigger inflammation and also malnutrition, muscle proteolysis in this particular population. Okay, let's focus your concentration into the left side of this picture first. So this is known as dialysis induced iatrogenic factors. So basically, what it means is that there are treatment related factors, clinical related factors that induce malnutrition in this particular population. For example, in advanced CKD patient that undergoing dialysis, yeah, we hemodialysis, for instance, yeah, so we create a dialysis access to them, yeah, and this process is actually introduce foreign elements, so it cause complement activation, it cause cytokine production, it cause because of the water in certain low resources setting, for instance, it causes the endotoxin and infection on the side and so on. All these contribute to inflammation. Yeah, in most of the patient, they have persistent chronic inflammation. On the same time, there are also insufficient of dialysis. Yeah, imagine our kidney working 24/7, but in dialysis setting, in dialysis patient, it may works for them only 4 hours, 3 times in a week. But I'm seeing in Indonesian setting or in other low resource setting, sometimes they only go for 2 times of dialysis, for instance. So the patient may not be adequately dialyzed, and this also contribute to the retention of the toxin and contribute to the metabolic acidosis and so on. Yeah. So these are all related to the dialysis procedure, the clinical procedure per se. Yeah. And of course, sometimes in low resource setting, yeah, we tend to reuse our dialyzer. When you reuse dialyzer, you actually tend to increase the loss of nutrients. That's include the amino acids, protein, and so on. So imagine what you are eating, then also being lost out in your artificial kidney. Yeah. So that's contribute to muscle proteolysis. On the other hand, there are some other non-clinical, non-dialysis related factors. You know, many of our patients that are reaching end-stage kidney disease, many of them, when they started undergoing dialysis, they are getting very tired. They can no longer work full time. Yeah, some of them may have to stop from working. So all these lead to their psychosocial factor. They have depression, they have anxiety, they have stress. Of course, when we are stressed, we are not eating well, isn't it? Financial constraint, all of this leads to, the availability of food that they can purchase and so on. But you know what? As a dietitian, as a nutritionist that is seeing them, we do sometimes advise them, to avoid eating here and eating that. Avoid eating fruits and vegetables, certain fruits and vegetables, because they are high in potassium. Avoid eating certain legume, for instance, because they are high in phosphorus. What happened to them? So what happened to them is that there are so many factors that they have to control. There are so many things that have control in diet. They end up eating the same things day in and day out. So what happened when you eating the same thing day in and day out? You will have a low dietary energy intake and dietary protein intake, and it doesn't meet the requirement, and all of these contribute to muscle proteolysis and malnutrition. So I hope I give you a clear overview, the pathophysiology, how malnutrition, or in the exact term, protein energy wasting, develop in the CKD population. Okay, so then what are the diagnostic criteria that we can use? So the diagnostic criteria has been established in 2008. It's quite some time ago, and uh, by um, I cannot remember. Uh, so yes, ISRNM, International Society of Renal Nutrition and Metabolism. But however, there are some issues with this guideline, or the criteria, in which I'm going to tell you a bit later. Okay. So then, ladies and gentlemen, why PU matters to you? Let's take a look into the prevalence of PU worldwide. Yeah. So there was a meta-analysis that has published that combined various observational studies that have been conducted in Malaysia, in Indonesia, in Thailand. Yeah, and they are reported about 52.8% prevalent, meaning that if you look at our dialysis patient, if you look at our advanced CKD patient, one in a two of them will have PU. But there are some heterogeneity in these particular studies because some of the instrument that they actually use in order to diagnose protein energy wasting is quite varies. Yeah. But let's zoom in into my country, Malaysia. So we have a nationwide study that we have conducted as part of my study, which called PASH, pump tocotrienol in chronic hemodialysis study, PASH study. So this was published by my colleague here, Steven et al. So we reported that the prevalence of PU is about 23% in Malaysia. Yeah. You can see here the range is can be up to 88% in certain of the studies because of either they have a smaller sample size or because of the heterogeneity in terms of the diagnostic criteria that they actually use. Many of them use certain screening tool such as malnutrition inflammation score and so on. All right, that's why they can see huge numbers over there. All right. Nevertheless, what we could do is that we did a pool prevalence. Pool prevalence meaning that you combine all of these studies and make a pool, and then you can get thousand of sample size from this pool prevalence. So we estimate about 31%, which is one in every three HD patient actually have PU, which is more, I think, reliable estimate. But how about in Indonesia? So I could not find, there's probably is, but I could not find any nationwide study that's surveying on protein energy wasting among CKD patient in Indonesia. But most of the studies are actually rather localized or very much specific for one institution. And having said that, is limited sample size, so we cannot really have a concluding indicators how severe is PU in Indonesia. But both of these studies are reporting PU for more than 50%, meaning 1 in 2% of your dialysis patient or your advanced CKD patient will have PU. So that's even more severe than what we actually observe in Malaysia, which is 1 in 3 patients. So what happened when patient have PU? Okay, so patient when they actually have PU, they will die early. Yeah, they do not live long enough for them to experience factors associated with overnutrition. You can see here, patient with PU, in terms of their survival outcome, they have much less survival compared to those without PU. And in fact, when we look further into those with PU, this is actually based, how do we get here? Is actually based on the score, which is using malnutrition inflammation score here. So those with more score of PU, yeah, more criteria of PU, most likely to die much earlier as compared to those with only one or zero criteria of PU, right? But how then to screen for PU in your particular population in Indonesia? Okay, let's go and go back to the guideline. What the guideline say? I'm referring here to the KDOKI guideline that was published in 2020. So the guideline talking about the usual care, blah blah blah. But more importantly, I outline about how you can assess nutrition status or screen the nutrition status for this particular population. So there are two tool or instrument that you can use. The first one is 7-point subjective global assessment or SGA, and the other one is MIS. SGA has a much higher evidence, which level 1B evidence compared to level 2B in MIS, yeah, malnutrition inflammation score. So this is how malnutrition inflammation score looks like. SGA, I'm sure all of you are quite familiar with that. Yeah, this is MIS score looks like. You can see that it comprises of some objective data, yeah, such as the change in dry weight, and also some subjective data, yeah, diet intake, GI symptom of your patient, in terms of the functional capacity, yeah. And then we need to do some physical examination of our patient to look at the fat store as well as to look at the muscle wasting on certain areas such as your temple, your clavicle, your scapula, your rib, and so on. Okay. And then some objective measures are on BMI, and also lab parameters that are looking for are on serum albumin, which is widely available. I'm sure that every dialysis center have to do serum albumin, and also on iron, total iron binding capacity. Right. So if they score 7 and above, that's mean they are in at risk of malnutrition. Okay. So there are some other screening tools though, even though they were not outlined in the guideline, but I'm sure that you have heard some other screening tool that being used in elderly, in being used in hospitalized patient, such as NRS 2002, malnutrition, universal screening tool, MUST, mini nutrition assessment, MNA. All of these, you can also use it, but please bear in mind that these are just a screening tool. Yeah, screening tools, meaning that after you screen your patient at risk of malnutrition, then you have to do further assessment to diagnose whether they really have protein energy wasting. All right. So this is an example of MNASF, short version of MNA that you can look at. Yeah. And this give us some of the form that you can actually download for your practice. So then after we screen and we tag patient, oh, this patient is actually at risk of malnutrition, then what you need to do is you then do further analysis, do further assessment to find out whether your patient is really having PEW, right? So what are the criteria then? This criteria was outlined by IISRNM. Yeah, it was published quite some time, 2008, but they are due for revision. But I'm going to tell you what the problem with this criteria. So in this particular criteria, there are four component or four domain that you have to look for. The first one, you want to look at the body mass, you want to look at the serum chemistry, you want to look at the muscle mass, and you want to look at diet intake. For body mass, you can use any of these indicator. You can use either you want to look at BMI. If patient having BMI less than 23, that is already a tick. Uh, that's mean that it's already fulfilled the criteria for body mass. Or better still, if you want to look at the unintentional weight loss, if they have losing more than 5% in a 3 month or more than 10% in 6 months, or if you have the mean to measure total body fat, yeah, if their total body fat less than 10%. So in it, either any of these criteria, either they have BMI 23 is already fulfill the body mass diagnostic criteria. Okay. So next is serum chemistry. For serum chemistry, you can look either at albumin level, you can look at pre-albumin level, or you can look at the serum cholesterol level. So it's very unlikely for a typical dialysis center to do pre-albumin because pre-albumin is relatively more expensive test to do. But serum albumin, I'm sure that in most dialysis center is readily available. It's being done at least every 3 months. So you can use this less than 3.8 gram per deciliter point. So if your patient having serum albumin less than 0.8 is already fulfill the serum chemistry component or domain. Okay, next is diet intake. So diet intake is a bit tricky, especially in a dialysis setting in a low resource setting where you don't have a dietitian. So as nurses, as dialysis technician, how you gonna do this is a bit challenging. Yeah, because you have to identify the intake of your patient and then calculate their intake and then determine what is their total energy and protein intake and divide it with their dry weight. So you're going to get dietary protein intake. If it is less than 0.8, then you're going to flag this patient. The same goes if their dietary energy intake less than 25 calorie per kilogram dry weight. So this is going to be an issue. But of course, for CKD, for those who have not yet undergoing dialysis, if they have less than 0.6 gram per kilogram per day, so this is going to be fulfilled for this diet intake criteria. But of course, diet intake to take diet intake of your patient, you would require some amount of training, yeah, in order to avoid underestimation and so on. So another component of protein energy wasting diagnostic criteria is on muscle mass. Yeah. So in this particular aspect, you want to look at the muscle wasting. If more than 5% reduced in 3 months, that means that you need to have your baseline muscle indicators of your patient. Or you can calculate mid upper arm muscle circumference, in which I'm going to tell you later. So this is the same criteria I'm talking about. Sorry, going back to here. So there are 4 domain, right? So if your patient meet 3 out of these 4 domain, then they are considered having protein energy wasting. But here's the problem. How to assess muscle mass? Yeah. You can see here there are several indicators that we can use. Reduce muscle mass by 5% or 10% over 6 months. So muscle mass, the gold standard for us to do it is using DEXA, but DEXA is not readily available. It's mostly for research purposes. So you can't really have access to this, yeah. And then is another thing is creatinine appearance. But to calculate creatinine appearance for those chronic hemodialysis patients is going to be problematic because many of them no longer have their renal residue, meaning that they are no longer urinating. Yeah, so this can be affected by other factors as well. So one of the simple tool that you can use in order to assess muscle mass is by taking their muscle mid arm muscle circumference. Yeah. So this can be a reliable marker for somatic protein reserve because MAMC provided a larger lean body indicator. Yeah, and it's also been associated to improve mental health, associated with longer lifetime and so on. But how to calculate mid-arm muscle circumference? So what you need to do is just this is actually based on the guideline. Yeah, basically you need to identify where your mid-arm circumference is, your acromiale, bony structures, and then radially, and then take in between measurements. Need to have some training to calculate this. Do the tricep skin fold. Yeah, skin fold is easy to do it, but it requires training. Otherwise, the mistake will be huge. Then your mid-arm muscle circumference. So you can then from them calculate your mid-arm muscle circumference. Okay, and then compare to it. So I'm not sure in Indonesia you have the reference in order to calculate this mid-arm muscle circumference. But in Malaysia, this was in our guideline for kidney patient. We use Francesco 1993 guideline, which literally derived from Caucasian population. So that's the problem because it's from the US, it does not really represent our local population. So what we did was that we did our own multi-center study. in which because it's quite common for us to do mid-arm muscle circumference, mid-arm assessment in all of our dialysis patients. So we have this pool of data, and we found out that, and we established our own nomogram, and we found out that our MAMC cutoff formulation male in HD patient, you can see here much lower than Caucasian. Yeah, because why? Caucasian generally present with a greater muscle mass. Yeah, due to the difference in genetic, diet, physical activity patterns, and so on. So that's very typical. So that's why it's best to use our own cutoff point. Yeah. And then the same thing, quite interesting, among females, that our female mid-arm muscle circumference are much higher than Caucasian. Yeah, this could be due to the higher in subcutaneous fat and adiposity. Yeah, so technically our female patient a bit higher than a general population in the US. All right. So this then address some of the critical limitation that if we rely based on Caucasian derived references. So that's why in Indonesia you have to establish your own nomogram, yeah, and make it as part of your clinical practice if you are a dietitian to to measure your mid-arm muscle circumference, because it can be easily be done, but it's required certain training. Yeah, if you are a researcher, do contact me if you want to collaborate. Then we can establish your own mid-arm muscle circumference for Indonesian CKD and dialysis population. Okay. So was a paper that we just published regarding this mid-arm muscle circumference cutoff. Okay. But ladies and gentlemen, at the clinic, this is the reality. Yeah. Um, this is what I do when I assess a normal patient. Yeah. But this is the reality when I see and assess kidney patient. You can see, she probably look overweight here, but in reality, yeah, if you properly assess, you do nutrition focused physical examination, you properly assess his muscle mass. There are a lot of adiposity, but her muscles is very low. Yeah. So it's not an easy way to assess it. You require some training, you require some additional staffing, and so on to help you with that. So is that, going back to the question, that is there any simpler method for diagnosis of protein energy wasting? Yeah. So I would like to bring you into this particular graph, which is indicating the general population, which is us, healthy population. You can see that as our BMI increase, our relative risk of death, anything more than one increase the risk. Yeah, relative risk of death is also increased. But that is very common because we can relate that as you get more BMI, you get more heavy. Um, you tend to get other metabolic condition, non-communicable diseases started to emerge, yeah, hypertension, diabetes, and so on. But again, this is quite unique in the sense that we see this among end-stage kidney disease and hemodialysis patient. When your BMI is increased, then your relative risk of death is going down even less than one. That means it's more protective. So, ladies and gentlemen, does it mean that we want our dialysis patient, we want our advanced CKD patient to be overweight and obese? Is that what it means based on this particular outcome? So it's not necessarily so. If we can refer what made those overweight and obese patient of hemodialysis or advanced CKD patient tend to stay longer or survive longer is not because of the BMI alone, but rather because they have higher skeletal muscle index, meaning that if those patients with much higher muscles, which also contribute to the BMI, then tend to stay longer, tend to survive longer on the dialysis treatment as compared to those with lower skeletal muscle index. So then we come out with one of the way how we can do make it simple in order to assess protein energy wasting. So I'm sure that many of you here have heard about bioelectrical impedance, because that is one of the device to assess your body composition that are now widely available. They are in the fitness centers, they are everywhere, even in clinic we have it, yeah, because relatively cheaper as compared to other type of tools. Yeah. So this was one of our paper that we published. We use in our clinic, there are several type of bioelectrical impedance or BIA that we have from various companies such as Seca, InBody, and in this particular uh, instrument is actually from Fresenius. This is from Fresenius BCM parameters. So in many of these BIA, modern BIA, they do measure face angle. Yeah, face angle is their raw measurements. Yeah, this is the face angle usually measured at 50 kilohertz. This is one the instrument that we have in our clinic. So what is phase angle? Phase angle is actually the phase shift between the current and voltage. Yeah. Um, and is actually indicator of the cellular deaths. So basically, what it means that the higher phase angle you have, that means it indicate that you may have increased muscle mass, you have increase in weight, you have a good supply of nutrient, and you reduce your water retention. Yeah. But if your face angle is showing downward trend, that means this is related to muscle wasting, weight reduction, malnutrition, edema, overtraining, and noxa damaging of the cell membranes. So based on our study, we identified that just looking into this raw outcome from this BIA, which nobody actually really look at it, yeah, which is face angle. Face angle can actually predict many of these PU criteria, PU based on ISRNM just now. So we established that the cutoff for male and female. So next time is that instead of you are measuring mid-arm muscle circumference, you have to measure the muscle mass for this particular population. Just use your face angle. Yeah, if you have it in this your clinic, just use this cutoff point to dictate whether your patient is actually having PU or not. All right. So with that, it's quite simple. So does it actually comparable? If you have different device name, does it comparable? So we have looked into two devices or three devices actually, at least, yeah, and we found that actually no different between whatever devices, yeah, that they use. So each of these devices, what make it different is that in terms of their formula that they actually use to calculate the percent of body fat, the percent of skeletal mass, and so on. Yeah. But their raw value, which is the face angle, is comparable. All right. So I think I'm come into the final slides. We are not able to go into the case. But what I'm trying to highlight is that so then what is next? After you identify this patient with protein energy wasting, of course you have to give treatment for this particular patient. But bear in mind, renal diet is quite complex. Yeah, because we dietitian previously used to be very restrictive. You impose a restriction to your patient. So at the end of the day, your patient monotony index increase, meaning that they are eating the same thing day in, day out. So patient with less variation in their diet will more likely uh, take less energy and take less protein. So that's why the guideline nowadays emphasize more on um, versatility, variability, and so on. It's no longer very restrictive as previously. So we're no longer imposing certain restriction on high potassium, high phosphate food, and so on. Yeah. So this is the reality. Yeah. To get food. So you may get a bomb. So translate this information is very difficult. That's why we can see here our patient adherence toward what we advise in terms of diet and in terms of fluid is very, very low compared to the medication or drugs. Yeah, the adherence is very low. So how to address them? How to treat protein energy wasting? So we found that nutrition counseling and oral nutrition supplements is your first line of treatment if you have this, but this require the role of dietitian, nurses, yeah, and also then the secondary aspect that you can move on is to use on top of oral nutrition supplement. If that doesn't work, then you can use IDPN, interdialectic parenteral nutrition. This is one of our study. We actually measure muscle mass using uh, using the apa uh, scan on the quadricep muscle thickness, yeah, using ultrasound, yeah. So you can see there are improvement in those group that are treated with nutrition supplement or ONS, yeah. So this is interdialectic parenteral nutrition. I don't have much time. I know. So what I can conclude from this particular session is that you need to have some cultural adaptation to the diagnostic criteria that has been established by ISRNM. That's why you have to have your cutoff point on mid-arm muscle circumference, for instance. Yeah. Otherwise, if you are using the cutoff point by Caucasian, you will likely overestimate your patient that are having protein energy wasting. Okay, so there are some simple diagnostic tool that you can actually use, such as if you have BIA, do leverage on it, yeah, by using the face angle. And what in terms of nutrition therapy, how do we treat protein energy wasting? Remember, it's a multidisciplinary. Nutrition is one of the component, but on the same time, other clinical factors must be also addressed. Make sure discuss with your fellow nephrologists about the dialysis adequacy, if there is an issue, yeah. Of course, on the inflammation aspect, yeah, on the exercise and so on, yeah. So teamwork among healthcare professional is a must, yeah, in order for us to improve the patient outcome. All right, with that, thank you very much. I'm sorry that we
Okay.
are not able to go through with this case study. All right.
Okay. Okay, thank you very much, Dr. Zulfitri, for sharing this valuable and interesting topic. Maybe we just have about 10 minutes to have discussion. And I think we have some question in chat room. Yeah, maybe from Mrs. Ria Ambarwati. One of the domains of ESRNM is serum testing, which is rarely performed due to the cost. When is this test performed and what is the time interval for early detection of PEUW?
Okay, thanks, Buria, for the questions. Yeah. So basically, for serum testing, I think it's quite standard for each of the dialysis center to do serum albumin at least, because serum albumin is very cheap. It's around RM3. It's RM3. How much? Yeah, in IDR. But it's rather cheap for each of the patient, and that's being done at least 3 to 6 months. Yeah, at least you can actually use on that particular test to do on pre-albumin, and also on cholesterol may not be readily available in your setting. Yeah, so I think that is quite readily available. So you can use going back to the interval for early detection of PU. So what is being recommended by KDOKI is that for a stable patient, stable meaning that they have been on dialysis for more than 6 months, there are no other some clinical issues that are happening to this particular patient. They're not in and out of the hospital due to inflammation and whatever. So in this stable patient, you do assessment every 6 months. Okay, but for newly patient that are in dialysis, yeah, within the last 3 months, then you may want to check on every month, and then once it has been stabilized a bit, you do on every 3 months. So that is what is being indicated in the guidelines. Okay, all right.
Okay, thank you. And the second is from Mrs. Marina. How reliable is MAMC as an indicator of muscle mass loss related to PAW among CKD patients, especially in different CKD stages and varying duration of hemodialysis?
Okay, very good question, Ibu Marina here. Basically, if I can go back to my diagnostic criteria of ISRNM, MAMC is a must for you to measure it because it is part of the diagnostic criteria. If you don't measure it, how are you going to know whether your patient meet all those at least three diagnostic criteria, isn't it? So then, next question is how reliable MAMC as indicator of muscle mass loss? So, for me here, what we have seen in our particular study, uh, um, usually you will be actually starting to lose muscle once you subjected to being undernutrition. You started to lose muscles, especially on the upper part of your body first. Yeah, that's why you can see losses in MAMC as well. Yeah. uh, so I think it is an easy way to do your muscle mass assessment. Okay.
Okay, I hope it's answered the question. Uh, because of this interesting topic, I think so many questions, Dr. Zulfitri, from
Mm.
Mrs. Yunarti. In clinical practice, the use of MAMC and skin fold measurement is often limited by ethnic variability and equipment accuracy. Based on your findings, what strategies do you recommend to better adapt MAMC cut-off values to local population in order to reduce diagnostic bias or misclassification of VEW?
Okay. All right. Um, how do I say it? Okay. Basically, um, MAMC, as I already emphasized just now, is a very easy method to do it. But often the limitation will come from the human error. Yeah, it's not so much based on ethnic variability. Because the ethnic variability would be based on what are the comparative standard that you want to compare to, right? The comparative standard here meaning that if you did MAMC and then you compare to Caucasian nomogram or or Caucasian data, and definitely you're gonna get overestimate. That's why in the very first place, what you need to do is you have to establish your Indonesian cutoff point first. Yeah, Indonesian cutoff point here because Indonesia is very big. We have various of
Yes,
ethnic, multi-ethnic, banyak pulaunya ya. Jadi
yeah,
perlu sampling itself must be representative. Uh, uh,
multi-center.
yeah, multi-center must be representative. Only then uh, it can be representative of certain ethnic group, certain ras dan sebagainya. Okay. Nevertheless, even we know there are four criteria, right? Usually, just by measuring at least three of the criteria, you can kind of know already whether your patient has PEW or not. Yeah, most of the time, patient will fulfill the serum criteria and then will fulfill the BMI criteria. And then the diet criteria, that one is a bit challenging because that is require you to carefully calculate and do not underestimate the patient's intake. So if that criteria is fulfilled, then it's good enough because it's already 3 out of 4. criteria. Okay.
Okay, we still have about 8 minutes. Maybe we have more two questions. Dr. Zulfitri, is there a sensitive indicator for monitoring improvement in cases of PEM in CKD patient?
Sensitive indicator. Okay. Uh, in order for patient to improve their muscle mass, it's going to be taking quite some time, right? But more sensitive indicator, what I've seen from our setting is you can look at face angle, change in face angle. That is very quick. And in fact, we use face angle in ICU patient as well. Yeah. You can see a patient who are improving their face angle has a lower hospital stay. Yeah, this within a few weeks, within 1 week or so on. So, but again, in a low resource setting, you may not have it. You don't have the BIA measurements, so that can be a problem, right? But at least you can, as a, from the perspective of a dietitian, let's say you don't have BIA in your setting, and in order for you to do measurement of muscle mass based on MMC, it's going to take some time. So what you can do is just looking at the intake. Yeah, if there are improvement in their intake, their appetite is getting better. Yeah, they are eating well, at least 80% of their requirement. So that's is actually a good enough indicator of improvement. Okay.
Okay. Okay, maybe the last one, Dr. Zulfitri. What are the practical messages for CKD patient to prevent PEM and have a better life with the disease?
Okay, what are the practical advice for CKD patient? It's going to be difficult, but I because it has to be very personalized to each of the
Okay.
CKD patient. But I can give advice to you as a professionals, health professional, what you could do. If you see your patients that having protein energy wasting, yeah, having protein energy wasting would require you to tag this patient and would require you to work multidisciplinary. Yeah, sometimes it's not just about diet. What
Yeah.
make patient, uh, you have to look at the main reason or underlying reason why this patient is not eating well in the first place. Yeah, sometimes it could be due to the stress factors, it could be due to the financial issues. How do you deal with these stress factors? I'm as dietitian, I'm not well versed and a right professionals to counsel this particular patient. So refer to the counselor and so on. Yeah. Imagine someone that is very stressed. How do you want to force this person to eat in the first place, right? So working multidisciplinary is very, very important. Yeah. I think I did some survey some time ago among Indonesian dietitian uh, in hemodialysis setting, in CKD setting. Only less than 10% of them actually communicating with their fellow nephrologists and doctors about their patient. So I think this is a global issue. We work individually rather than we work in a team. We see a patient, okay, the patient, doctor refer us, the doctor refer the patient to us. We see the patient as it is. Yeah. We don't
Yes,
really talk to our counter nephrologists or more importantly, nurses. Nurses and dialysis technician, they are seeing this patient on daily basis. So they all know all the gossip about the patient. They are the master. All right. So talking to each other is very, very important in order to treat your CKD patient with PU. Okay. I hope that
okay.
is clear.
Okay. Thank you very much. So it's about interprofessional collaboration. Yeah.
Correct.
Yeah. That's an important thing. Okay, ladies and gentlemen, we have about to end the session with Dr. Zulfitri. Uh, maybe we can see in another time. I believe that you have a great time and happily learning through this webinar with Dr. Zulfitri. Finally, on behalf of International Online Seminar Committee, I would like to express our appreciation to Dr. Zulfitri for sharing valuable information and knowledge. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. See you.
Terima kasih banyak semua.
Yeah.
Okey, terima kasih.
All right. Thank you. Yes, I could hear you, but I couldn't unmute myself. Hello. Oh, you can hear me.
Okay, good morning. Okay, good afternoon. Yeah. Good morning, everyone. Welcome to today's International Conference on Handling Non-Communication Disease. In this session is the theme of Bridging Policy and Technology, Strengthening Health Information Ecosystem for Kidney Health Equity. Okay, my name is Siti Masroha, and I will your moderator for this session. We have an exciting lineup of speakers today who will share their insight on. Hello, Mrs. Cecilia. Hello.
Hello. Yeah.
Okay.
Yeah.
Is my voice clear? Clearly? Okay.
Say that again, please.
Okay. Okay. Uh, for your presentation is at 9:45 this morning, so make sure to stay tuned in until the end. Okay, and then we will be share to your mohon izin. Okay, let me introduce our speaker, Mrs. Cecilia and Magister Shem, Head Informatics, who is Head Informatics, HIM Education, Digital Head, Clinical Coding Expert, and Mrs. Cecilia is Passionate Head Information Management or HIM, and Head Informatics Professional with over a decade of experience advancing head data quality, clinical documentation, and capacity building in Nigeria. She holds a master degree in head informatics from Swansea University, United Kingdom, and is a global professional member of the American Health Information Management Association, or AHIMA. And she associated member of the International Federation of Health Information Management Association, or IFHIMA. Okay. So she is amazing. We say hello there. Hello, Miss Cecilia. We will be discussing bridging policy and technologies technique health information ecosystem for kidney health equity. Okay. Please welcome welcome to Mrs. Celia to presentation. Okay.
All right. Thank you, everybody. It's morning here. Good morning. I hope it's still morning with you too. Good morning. Yeah, today we are looking at bridging policy and technology, strengthening health information ecosystem for kidney health equity. So we are going to look at what is kidney disease. Before I go on, I want to thank the brain behind this topic, because while I was doing my research, it actually opened me up to so many information about kidney health disease. As a clinical coder that works in the hospital, we have encounters with kidney diseases, but while researching, I got to know some other things that I wouldn't have thought of, like the major challenge in kidney diseases. I don't know, can my slide be up, please? Or you want me to share from here?
For your presentation. And
Uh, would you give me the permission to share my slide, or you share it for me? So let's start at the introduction. All right, I think that is taking time. So I would continue starting from the introduction. So kidney disease and kidney failure unequally affect vulnerable population, and we have an estimate of over 50 million people worldwide affected by kidney disease. Okay. Okay. Affected by kidney diseases. You know, the structural inequities, social determinants of health, and gaps in care contribute to this. And also, early detection, management, and outcome, particularly among low-income, rural, and minority population. So this is establishing the fact that all over the world, there is a gap in the early detection of chronic kidney diseases. This could be due to social or cultural factor, uh, economical factor, and sometimes racial biases. But it is a problem. And today we are going to look at how we can use technology, especially in health information management, to solve this problem. So we are proposing that a robust health information ecosystem can help identify the gaps, guide interventions, and monitor equity, supporting the goal of Global Kidney Health Initiative. So what is the major challenges that we have when it comes to health equity in kidney disease? We have social determinants and structural inequities. So income is one of it. Uh, depends on how much is being made by particular family. As you know, these diseases, they are quite expensive to maintain. When somebody is uh, when somebody has kidney disease, that means this person would have to go for dialysis, and almost maybe sometimes it could be a week, 2 weeks, or a month, depending on how far gone the person is down with that disease. And this can be very expensive. So in an household where the income is minimal, so this means that they would not go for the treatment. So the income is a challenge. Then education. The level of education determines how seriously you take your health challenges. So if an educated person is told you have kidney disease, so this person knows the meaning of kidney disease and how it can affect them. But somebody that is not aware would still be seeking for information, trying to know, oh, what do you think I can do? What can help me and all that. But somebody that is well educated knows that, oh, this is a particular challenge and this is something I should take seriously. So by the mere mention of it. Then another thing is access to healthcare. So in some rural areas, there is no free access to healthcare. Primary care centers that are close to people, there is no access to the healthcare that can actually help in the early detection of these diseases before it gone to the further stage. So these factors affect the risk and the care for kidney diseases. Another gap is awareness and diagnosis. So studies have shown that many people that have chronic kidney diseases, they don't know, they are not aware because they don't have access to healthcare, or because it's not, the detection of chronic disease, chronic kidney disease is not something that you can say, oh, there's intervention for HIV, there's intervention for COVID-19, there's intervention for cancer, that people need to take tests maybe once a year. But the same thing is not available to chronic diseases like the kidney disease we are talking about. So another factor in kidney disease is the geographic disparities. Remote and rural population face higher risk of delayed diagnosis and reduced access to specialist care. So if the kidney disease has gone from stage 1 to stage 2 or to stage 3, then it means that there is need for specialist treatment. There's need to assess care in a specialist manner. And when you started having dialysis for the treatment of these kidney diseases. So these are some of the things, the challenges that we face with health equity in kidney disease. And this is so because there's information gap. There's information gap that people are not so aware of what they need to do when it comes to the prevention of kidney diseases. It is not so rampant. Thankfully, there are so many research on kidney diseases, but the knowledge gap is still there because it's not like, for everybody knows that HIV/AIDS is transferred through sexual intercourse, sharing of sharp objects, and the rest like that. So the awareness for those ones are there. But for kidney disease, those awareness is not there. And people living in rural area, uh, low-income communities and the rest like that, they would majorly have challenges with this. So let's look at the framework. There have been so many frameworks that has been proposed when it comes to kidney health equity. This framework is to aid early detection. So let's look at the kidney care health equity framework. So it says the purpose is to define kidney health equity across the disease continuum, that is from the start till the end of life, and provide a structured approach to identify and address disparities developed through stakeholders' consensus. So stakeholders came together and said, oh, let us define this kidney health equity, because they are trying to say that, yes, this kidney diseases is prevalent. Let's look for a way to address it so that even the underserved population can benefit from it. So what has this framework achieved? It provided a blueprint for equity-focused intervention, unified kidney community around equity goals, highlighted priority domains for structural community, clinical and patient level intervention. So it just means that they are coming together to ensure that patients, people that come down with kidney disease actually have the means, irrespective of their background, of their race, of their income status, and all of that, they have access to care. Then we have the London Kidney Network Health Equity Group. This group ensures equitable kidney care access across London, addressing disparity by socio-economic, geographic, and demographic factor. So if we look at all, I think I have about 5 frameworks there. The major thing that every of these framework is advocating for is equity, early detection of kidney disease, access to care, irrespective of who you are, where you live, your income, your status, because it is very important that you have access to care. Can we move on to the next slide? Okay. There are still some other I've explained the frameworks. They all have the same goal anyway. There are different frameworks. They all have the same goal. Even beyond what I've written down, there are other frameworks too that we can look at. There is a particular framework that is so concerned with race, making kidney health available to everybody, irrespective of your race and all that. Now, as health information or healthcare providers, how do we strengthen this ecosystem? How do we use health information ecosystem to strengthening kidney health equity? How? So the number one thing I wrote is robust data collection and integration. Now, the the value of a healthcare system is measured by the services provided in terms of patients seen, cases attended to, treatment given, death rates, and health rates. You know, this is what is being measured. But if there is no data, how do we measure these factors? How do we know that an hospital is doing well compared to others? And as health information professional, our top duty is to collect data. We collect data, we generate data. We are not the only one that generates data in the hospital. The doctors generate data, the nurses generate data, the lab attendants, the radiographer, all healthcare providers generate data. But this generation of data starts with the health information department. It starts with the patient approaching the hospital, where you collect the biodata, which will now be developed into clinical data and all that, comprising of doctor's clerking, nurse's notes, the lab, the radiography, and whatever services the patient have access to within the healthcare. So it is our duty to collect robust data so that in collecting this data, we have information about number of cases that has to do with kidney health. And not just with kidney health, we have the age disparity of patients. We want to look at the most vulnerable groups. The most vulnerable groups we are looking at. We want to look at the factors surrounding their health conditions. All this information are what we use. And under this robust data collection and integration, another thing that has been a major challenge is interoperability. Yes, we are adapting fast to electronic health record. But then, in this adaptation, we have different versions of electronic health record that are not communicating with each other. And that is where the issue of interoperability comes in. If each electronic system is not communicating with each other, it means that all our data is fragmented, is in silos. Hospital A has their own data. Hospital B has our own data. Hospital A data and Hospital B data is not communicating, even though we are trying to achieve the same purpose. So interoperability is a major challenge, and this is one of the things we should be looking at as health information people. Then another ways to strengthen kidney health equity through health information ecosystem is advanced analytics and monitoring. So we don't just collect this data. We need to develop dashboards, reports to visualize disparities in chronic kidney disease detection, management, and outcomes. We need to use predictive modeling to identify patients at high risk of progression or poor outcomes. So what I'm trying to say is that as health information person, it's not enough that you collect data. You should be able to make sense of the data that you collect. You should be able to compare. You should be able to draw out predictions from the data that you collect. There are so many instruments that we can use to do this. From the EHR dashboard, we can do this. From Excel, we can do this. From Tableau, SQL, and all that, we can do this. And we need to continue to look at how to improve our work process and not just collect the data. Because if you collect data and it's unused, it's as good as not collecting it. So there's no use for it. This is why we need to draw out information from the data we have collected. Draw out information so that stakeholders, people planning healthcare services can see the impact of that data that you have with you. Then number 3, governance, ethics, and privacy. That is, I said, establish ethical oversight framework for equitable and responsible use of health data. Now, this is very important. We all are very personal when it comes to our data. Nobody wants their data flying around, irrespective of, oh, you come into the hospital to receive treatment. Yes, but you don't want that information outside. This is why there's need to govern the data. There's need for policy on privacy and ethics. Whoever is privileged to have those information must understand confidentiality. Patient information is not an information to display or to talk about or to gossip about. We must maintain utmost confidentiality when dealing with patient information. And we must have processes in place. Now, it is okay that when we have patient information, there are things that happen that there will be need to release patient information. So there should be policies in place that guides against the release of patient information, how it is released, who you are releasing to, and what is the purpose of the release, the authorization for release. All these processes must be in place if we are trying to govern patient privacy, ethics, and governance. Number 4, capacity building and workforce development. Capacity building and workforce development. Now, in the health sector, health information personnel cannot do it alone. We all are working together, the doctors, nurses, health information, the lab person, and all that. We are all working together to make everything work. So there is need to train clinicians and healthcare staff to use health information system for equity and informed decision making. That is, we must be willing to adopt the use of maybe mobile health apps, electronic health records, telemedicine, all those health information tools that makes our work seamless, that makes it easy. We must be able and open to use them. We should build data literacy among healthcare providers and community health workers. We should let them know the importance of health data literacy. Why do they need to safeguard patient information? Why do you need to maintain utmost confidentiality when dealing with patient information? These are the things that we need to be looking at. Technology and digital provide access to reliable internet device and platform for clinics and patients. Design low bandwidth and localized solutions suitable for resource-limited environments. Use telehealth and remote monitoring to manage chronic kidney disease in rural and underserved areas. Deploy patient-centered tools like apps, SMS reminders, or portals to enhance engagement and adherence. So in doing all this, we are not just trying to train healthcare professionals in the use and adoption of digital health. There's also need to train the patients, as they will be at the receiving end, and they should know how to use these common tools so that they will be able to monitor their own health. And we have so many ways in which patients can monitor their health. We have digital smartwatches. It could be an SMS reminder, a mobile app on their phone, just to monitor the progress of their health, or just to remind them of taking a particular medication, an appointment, a time for tests, all that. So we have a lot of work to do in sensitizing the patients on digital tools. Then another thing that can help us is sustainability and continuous improvement. So under sustainability, we need to monitor equity metrics continuously. and assess the impact of intervention. Yes, if we have given an intervention, let us look at it. This intervention that we provided, what is the result? Positive, negative, where do we need improvement? Apply iterative learning to improve care processes based on data insight. Yes, data insight is very important. Like, I want to cite an example of the COVID-19. During the COVID-19 in my country, health information professionals daily, we collect data about new cases, follow-up cases, and all that. So that is data insight. We are giving feedback every day on what is happening, what is the latest development. Then align health information system with policy and funding priorities for long-term sustainability. So in aligning health information with policy and priorities for long-term sustainability, I think the policy will still involve the use of data, to use data to release this information to. Yes, these people want to sponsor this particular project. And in sponsoring that project, you need to know who is in charge. What are they asking for? You don't just release patient information. And this even brings to mind that health data is very important. If they are going to sponsor anything, if there's going to be any intervention, they need to see a data that says that, oh, this particular population is highly affected. This set of people in this particular community is highly affected. So that is where they direct the intervention to. The data is making it possible for them to direct the intervention. Foster cross-sector partnership with government, NGOs, and private sector for resources and innovation. It's just like what I've mentioned. All these people will come together to say, oh, we need this particular data. Can you provide it? As a health information person, you should have this data, and you will guide against how you release this information. That is very important. Then lastly, community engagement and advocacy. So co-design intervention with patients and local communities, conduct targeted educational campaigns informed by health data. And I intentionally put informed by health data so that we know that whatever we are doing, we are guided by data. And it's not just something that we are taking from top of our head. There's a data to back our intervention up. There's a data that says that there's a gap and we need to back this up. There's a data that says that we need interventions and all that so that we can move forward. So what are the benefits and impact of when we strengthen health information ecosystem? What are the benefits? Number one, it's improved early detection, diagnosis and management of chronic kidney disease in the underserved population. Two, equitable pathway, reducing disparity in treatment and outcome. Three, data-driven targeted intervention informed by integrated analytics. Four, community empowerment through engagement, co-design, and cultural sensitivity intervention. And lastly, policy leverage to inform resource planning, clinical guidelines, and quality programs globally. So you would know that in all I have said, there's one thing that I keep stressing, and that is data. There is need for data. There is need for analytics, visualization of data. So what are the challenges? We have data privacy and consent challenges, interoperability and integration, limitation across system. I think I have explained this before, because system does not communicate with each other. We have different type of electronic health record system, and they are not communicating with each other. Everybody is developing their own software. Patient information cannot transfer from hospital A to hospital B without manual process. I'm talking in light of universal access. Just say, if I go to Africa, if I go to Asia, if I go to Australia, I'm able to just type in my name in their electronic health record system, and my health history is brought up. We have not gotten to that stage where interoperability is universal. There are some systems that within an organization, within a local community, that communicate with each other, but it is not expanded. It has not gone beyond what we are talking about. It has not gone beyond the horizon of that particular district. So there is need for us to have interoperability, and interoperability is just letting your information be available wherever and whenever you go. But that is not done. Now, potential biases in AI and predictive models. So these are the challenges. AI can be biased depending on the information that is used to train AI. And they can give you or mislead you when interpreting information. Sustaining multi-sector collaboration and funding. Limited technology adoption in low resources settings. Yeah, there are still some settings that they don't even have electronic record system, app, telehealth, and the rest like that. They don't have it. Resistance from clinicians or communities to new system or data collection practice. If you are trying to collect data, maybe to measure a particular trend of disease, so people are very resistant when it comes to giving out information. They don't want to give out information, and these can greatly impact what we can do with data. If we don't have enough data, all this intervention funding will not be possible. So I left some few case studies. National Kidney Foundation CKD Spotlight Dashboard. So this is like the health information system that has been developed in health diseases. So the National Kidney Foundation Chronic Kidney Disease Spotlight Dashboard is just showing data of people affected by of countries with the disease that the kidney disease that is being affected by each country. That is what the dashboard is showing. But studies also show that some these data are underreported. So it is not a true picture of what is happening, but that is what they could lay hands on. The same thing with Territory Kidney Care Australia. They are doing the same thing, trying to put patient information together in kidney disease and trying to make sure that these data are readily available for whoever needs it. The AI Health Equity and the Raise KD Consortium, they are just examples of the intervention that is in place for kidney disease at the moment. So what do I recommend? So we've come together and said that, oh, kidney disease, there's knowledge gap, there is not always detected on time. There is disparity between the low income and middle income, all that. We've said all this, that this is the challenge. So what do we do? Well, we've said all this, we've said what we can do. So I say pilot projects in high need settings, including low resources and remote community. This means that we should particularly target low resources and remote communities so that we can carry them along and nobody will be left behind when it comes to kidney health equities. Stakeholders engagement from the outset. So who are the stakeholders? The patients, the clinician, the community leaders, and policy makers. Those are the stakeholders, and we need to engage them. We need to let them know. And I say particularly with the patients. With the patients, they need to be aware of their health. And there should be intervention that would make it possible for early detection of kidney diseases. Establish governance structure for data use, privacy, and accountability. Yes, it is very important that we guide the use of data, privacy, and accountability. Who is responsible? Who is feeding the NGOs, the people that want to intervene in the kidney disease? What information are we giving them? Are we giving them the right information? Is our information up to date? Invest in capacity building, training, that is training clinical informatics, data science, and culturally competent care. So I have mentioned from the beginning that it is very important that when you collect data, you visualize it, use dashboard, draw out meaningful points from the data, not just to collect the data and keep it. You need to draw out conclusions, points, point stakeholders to what is most important. Set up equity-focused evaluation metrics stratified by socioeconomic status, geography, and ethnicity. So that is what that is saying is that in our data collection, let it be obvious, let it show that this is what you are trying to pass across. What is the status? What is the geographical location? What is the ethnicity of these people? Who are mostly affected? What do you need to do? And these are the recommendations. Then lastly, advocate supportive policy, funding, data infrastructure, and incentive equity-driven outcomes. So how that you might still ask yourself, so how do we strengthen health information ecosystem? What do we need to do to ensure kidney health equity? I said establish kidney health equity frameworks. When combined with strengthened health information system, provide actionable strategies to reduce disparity, improve outcomes, and advance global kidney health equity. And this means that the advancement, the justification for kidney health equity lies with health information systems. How we are able to bring those systems together to report data, to visualize data, to ensure privacy, to build capacity. This is what will help us. Thank you very much.
Okay, it's amazing from Mrs. Cecilia. Okay, then we now still move on the QA session. Okay, Mrs. Cecilia.
Yeah.
I think question. This question for you. If you have any question from the
Yeah, if there's a question, I'll be happy to take it.
Okay, let's start with the first question from Mr. Yevan. Okay.
Okay.
Okay. As a medical record or him, how do you see the role of daily collected data, such as address, occupation, or medical history in actively helping the health system identify and track disparity in access and treatment outcome for kidney disease. Okay.
Oh, okay.
Mr. Yafar is raised hand. Okay.
Okay. Do you want me to go ahead?
Yes.
Okay. So you've asked question about what do I feel about the name, addresses, all those information being collected in the hospital. Hope I got the question right. So I think those are the basis for health data in the healthcare. And we as health information management professional, we are in charge of asking those questions. Oh, madam, good morning today. What is your name? Your age? You know, sometimes people are resistant to giving you those information because they believe they are just coming to the hospital. Oh, I'm just having malaria. I just want to get medicine and go. Why are you asking me all those questions? So it's left for you as that information person to explain to them that, oh, this information is very important. Even your age would determine the type of drug we are going to give you. Your age can determine the type of drug we are going to give you. Your background, your social economic background can give us means of giving you intervention that will help you in your health care. So all this information that we collect in the hospital, they have a reason. There's a reason that we are collecting it. And it is important. Sometimes when you are asking patients, they just give you their name and those names are not correct. It is left to you to ask, oh, is this how you spell your name? Because it is very important that you get the patient's name correctly. And in a case, I've had a situation where patients will give their first name and their surname. Then you ask them for their middle name. They said they don't have middle name. You know, it's a big war. You said, I don't have middle name. Then I take my time to explain to them that it is important that you have a middle name so that we can distinguish you from others. There might be somebody bearing this same name that you are bearing, and there are instances where the first name and the last name are the same. So how do we distinguish you from the other person? So give us your middle name. And even when we have the same name, the same surname, it is possible that the address will be different. There are other indicators that will show you that this patient A is different from this patient B, even though they have the same name. So, but it's important that at the point of registration, you collect the right information from patients. You let them know the essence. If they're asking you questions, it is not a time to fight them. It's a time to explain to them, this is why I'm collecting your information. This is what we are going to use your information to do. And the fact that you can assure them that their information is secure in your hospital, I think they will be able to cooperate with you. Thank you.
Thank you for the second question. For the participant who will ask question, please, Mr. Yefan, to ask. See, he is okay. Okay, Mr. Yefan. Okay, Mr. Yefan. Okay. It's problem. Mute mic.
Yeah, hey, Mr. Zeban. Yeah, same here.
Yeah. In your capacity building and technology inclusion, yeah, as essential pillars. So, as we know, like Indonesia, often face digital infrastructure limitation, like internet or electricity, hardware, and especially in rural areas, and lack a trained workforce in clinical informatics and data science. So my question is, what is priority strategy should the government or the Ministry of Health adopt to address the fundamental challenge so that the kidney health information ecosystem can function equitably and sustainable.
All right.
Is it clear, Cecilia?
Yeah, it's clear.
Yeah.
Thank you for your question. Yeah, it's not, I don't think it's only in Indonesia that we are having a technological problem and adoption of technology and the rest like that. I could say of Nigeria. So we've adopted technology to a certain level, and I think everything is coming together now. But then, this does not mean that we are without challenges. There is always challenge, from electricity to network setup, electronic health record, and the rest like that. So it has always been a major challenge. But I'm somebody that believes that, okay, before you go to the government, as individual, as health information person, what skill do you have in that particular area? Because it is not enough to just go to the government. You must know what you want to go and present to the government. You must have an understanding of what you want before going to the government. So the major question I'll be asking, how are you developing yourself as health information manager, as health information professionals? How are you developing yourself to make yourself a center of attraction for those things? Because when electronic health record implementation comes in, are you positioned for it? Do you have the knowledge, the skill to identify which electronic health record is the best, what an electronic health record is supposed to have for it to function properly in your rural community or in your community? So you need to know all those ones. You need to have the knowledge of that. So developing yourself will be my own start point. Then when we develop ourselves, we will not do a form of advocacy. Advocacy in the terms of researching the problem. This is the problem. This is the solution. If we have this, this is what we are able to achieve. That is when you present it to the government. So this could be in form of policy or a white paper that you can come together, write about it. These are the challenges. These are the skill sets that we have. This is what we are proposing. At the first phase, we are hoping that we can achieve this. At the second phase, we are hoping that we can achieve that next. Then the third stage, because when you do that, the government knows that, oh, this set of people know what they are doing. Because if you are presenting a case to the government and they say, okay, who can you give us to champion this? Who can liaise with professionals? Who can talk with these people to get this done? So what do we do then? We go back to say, oh, I'm not competent. I don't have the expertise, So it doesn't speak well. We have to develop ourselves. Then research about the research in the time I'm saying is not because you don't know what is happening, but I want us to back it up with figures, with information, something that is tangible. When you are coming with evidence, there is no way you can say, oh, it's not happening. But this is the evidence, it is happening. And I believe that would help. And for health information professional, the other time I mentioned that not just collecting data, you need to be able to interpret your data, to predict, to draw conclusions, to compare. So it's not enough that you are collecting data. This is the era where you start making use of that data. What is this data telling me? What is the trend? If you are able to present that, you are presenting information. But if your data is in the raw fact, always in case notes, always in the index card for coding, nobody is seeing anything. Nobody can come to your office and be checking it one after the other. You have to present it in a format like an evidence. I hope I have been able to answer your question.
Okay. Once again, Cecilia, as a medical record, in Indonesia, medical record is health information management.
Yeah.
If you were design electronic medical record form for chronic kidney disease, so what specific social determinant of health data points do you believe are the most critical to record, and how can documenting this data to help physician or doctor or nurse create more equitable care plan for patient?
Okay. Let me answer the question by saying, for example, if a patient is coming to the hospital and we don't know if this patient has chronic kidney disease, because that is usually the case, normal people like you and me go to the hospital. So it takes several tests to determine this. I think with the information that we now have, I think it should be a priority that at the point of data collection, we would have, aside from the name, the address, the biodata, we would have a section that talks about the lifestyle of the patient. We have a section that talks about the comorbidities. So we all know the comorbidities that can eventually lead to kidney diseases like diabetes, hypertension, like that. So we should have information about the comorbidity, the lifestyle of the person, then family history too will go a long way. I know that there are family history when we are collecting data about asthma, diabetes, cancer. You understand what I'm saying? So I think it is at this point we should be asking, has anybody in your family been down with kidney disease before? Does any one of them have kidney disease? I think that is another aspect we should add to it. Then another thing I think we should add, if the government will take this up, is yearly test. So there are so many ways we can test for kidney disease, maybe through the urine, albumin, creatinine procedure, or the estimated glomerular rate. So if they make it mandatory that every year people test, and when they test, we want to monitor the level. What is the level this year? So if you see that, oh, this is just mild or progressing into a kidney disease, then intervention should be started immediately. I think that will help. And when it comes to electronic health record, it is important that we know that when transitioning to electronic health record, the same manual that we are using, how we enter our information manually and everything like that, those are what we need to develop a complete electronic health record system. If that is not in place, or we are just developing it off and on, one thing I found out is that software developers, they are not really health information or health care personnel. So they just develop these things without knowing what is expected, what they need to put inside it and all that. So, and at the end of the day, there's need for correction, recorrection, and you will see that the danger thing is that it does not suit. It does not suit purpose. Thank you.
Thank you, Cecilia, and see you next week in ICOMRI.
There is still
All right.
five.
See you next week.
Okay, there is still 5 minutes left. Once again, from Mr. Arif Darmawan. Thank you for presentation, Mrs. Cecilia. I have question related to your recommendation. How can wearable device like smartwatch be used to support these strategies, especially for monitoring patient with kidney disease? For example, smartwatch can track blood pressure, heart rate, track blood pressure, and physical activity. How can this data help improve early detection and follow-up care in low resources or remote communities? And what challenge should we consider, such privacy, data sharing, or fairness for patients from different socio-economic background? Okay.
Okay, thank you for that question. As of now, I don't think there is any smartwatch that can help detect chronic kidney disease. But I have put smartwatch there because it can like notify you when you have appointment. It can notify you when you need to take your drug, so you can use it for that purpose. And I think if we look into it deeply, I'm not a software developer, I'm not an engineer, but if we look at it deeply, there are ways uh, to which we can actually use it to detect, because um, there is a rate that we should have. If we can measure our blood pressure with our hand, and the diabetes, there's a way that we now measure diabetes too in through smartwatches. So I believe with that, if people that are in that position really look into it, we'll be able to achieve that. But for now, there's no particular smartwatch that can do this. Then uh um to when it comes to the privacy and all that aspect of it, what I can say is that for mobile health apps or smartwatches, combining it together, there is a privacy law that doesn't allow them to share your information. So when signing up for these mobile devices, you need to read the privacy guideline very well and know what you are signing up for. If you are not comfortable with it, do not sign. But in the EU, information that you are going to give, you have to consent to it. If you do not consent to it, nobody can take your information.
Okay.
So I think it's good that we know that.
Okay. Okay. Yes, thanks for this. Tema is amazing. Okay, can we to conclusion with the discussion then strengthening the health information ecosystem is the key strategy. This efforts using established kidney health equity framework such as LKCEHI and EDTK anti-racist framework and NKF initiative combined with 6 pillars. Okay, for information systems, one, robust data collection integration, advanced analytic and monitoring, governance, ethic and privacy, capacity building and workforce
Governance.
development, technology and digital inclusion, community engagement and advocacy. Okay, expected impact. This approach is expected to improve early detection, create equitable care pathway, drive data-driven intervention, and empower community. Okay, establish equity framework when boosted by robust health information system, provide actionable strategies to reduce disparities and advance global kidney health equity. Okay, well, the wraps up our conference for today. Thank you, Mrs. Cecilia, for joining us and for the great question. Special thank you to our speaker for their valuable insight. We hope you found this session informative and inspiring. Okay, have a good day. With applause,
Thank you.
to Mrs. Cecilia. Thank you.
Thank you so much. Thank you so much.
Okay, thank you very much.
Okay, thank you, ladies and gentlemen. Before we proceed to the next agenda, allow me to extend our sincere appreciation to our distinguished speaker and moderator of session 2 for the insightful presentation and meaningful discussion that has enriched our understanding this morning. Excuse me, Miss Cecilia 8th and Dr. Siti Masroha, please remain on the screen. We would hand over the certificate for the honorable speaker. Thank you very much. We truly hope that in the future we will have the opportunity to welcome the honorable speaker to Poltekkes Kemenkes Semarang in person and continue
Thank you.
strengthening our collaboration through direct engagement and shared learning. Thank you once again, and we wish you both the very best to continue your agenda.
Thank you.
Ladies and gentlemen, as we continue to strengthen the academic ecosystem within Poltekkes Kemenkes Semarang, we are committed to advising our global engagement and expanding our international
Well, thank you very much for our MC for leading the session so well. So, hello, good morning, Miss Catherine. Is my voice audible?
Yes, hi, good morning.
Okay, it's very pleasure to meet you, Miss Catherine. So, distinguished ladies and gentlemen, please allow me to introduce our third speaker for today's agenda, Catherine Clark, RM, MSc, and PhD.
Thank you so much.
Yeah, she is a specialist midwife and researchers focus on kidney and blood pressure disorder of pregnancy. And she has a completed PhD at King's College London titled A Kidney Injury in Pregnancy, Improving Diagnosis, Prediction, and is now a research fellow working on the same with the CRIPS and Cradle groups, predominantly in low and middle income settings. Catherine is a founder and co-lead of the Global PRACI Consortium and has held multiple expert positions in national and international clinical and research groups. Catherine is passionate about optimizing the role of midwives in the identification and modification on risk for long-term renal and cardiovascular disease. On this occasion, Catherine will deliver the material about the strengthening maternity protocols, optimizing pregnancy and postpartum care to detect and prevent kidney disease after hypertensive and other known risk events. So let's please give a warm welcome to Catherine Clark. The time and screen are all yours.
Thank you so much. And I need to start by saying thank you to the hosts for welcoming me and indeed inviting me to be part of this important meeting. So let me just share my screen. Super. So thanks so much, Techie. It's just so great to be part of a group where midwifery is really valued. And I think when you're from a country like the UK, where midwifery has been core for a long time, it's great hearing how midwifery plays such an important role in other places around the world. So it's great to be part of this group. Thank you. So just a bit about my background. So as already been shared, I do my research and teaching through King's College London, and I've done most of my clinical work at King's College Hospital, which is that building on the bottom left. And I think both of those buildings look very British in their architecture. But now I am based in Singapore, and so I do spend a fair bit more time over this side of the world. So I'm not so far away from you at the moment. And I need to acknowledge that I'm coming at this as a midwife first and foremost, but also as a parent to 2 kids. And I think these influences definitely shape my view of this topic. Before we start anything, I think it's particularly when we're thinking about women's health, we need to think about the experiences that women that we're going to be discussing the journeys of have had. And so these are some quotes from women who've had acute kidney injury related to pregnancy. Some from the UK, some from Africa, and some from Malaysia. So one woman said, "I didn't know what was happening. I thought I was going to die." Someone else said, "I would pray sometimes to God to take my life, but my children are too young." And the third quote here is, "They told me it was too late. Why didn't they see it earlier?" And I think as we go through the talk, it's important to remember that a lot of what we're talking about might have clinical reflections for you guys, but also personal reflections for the women that we're looking after. So the plan for my talk is to think about the problem that we face when we're looking after women who are having pregnancy with kidney disease, or indeed who develop new problems in pregnancy that increase their risk of kidney disease, and what we are at risk of missing. Then think about what those long-term risks are and what the evidence tells us. Think about the care pathways and what better might look like within our resource limitations. And then also think about the solutions. So if we're stood here today and we go back to our workplace tomorrow, what can we implement as healthcare professionals from tomorrow? But always it's important to start with a little bit of revision to make sure that we're coming at this from the right angle. So the first thing, and this won't be new to some of you, but maybe to others it will. So the kidney workload massively increases in pregnancy. So we think of the placenta as a very vascular organ. Indeed, 700 mils of blood enter the placenta every minute, but 2,000 mils of blood enter the kidney every minute. And that's 20% of the total blood pumped by the heart. So indeed, the kidneys have to increase their workload, and some people would argue that pregnancy is a cure for kidney disease. You see creatinine reducing, you're seeing GFR go up. But we need to remember that obviously the kidneys are full of capillaries, 10 kilometers worth of capillaries. And so the vasculature and the way the kidneys respond to this stress test that is pregnancy is a real barometer of cardiovascular and vascular health. And so we can really view pregnancy as a cardiorenal stress test. If you look at this graph on the left, you can see those women who have a healthy pregnancy. Indeed, this graph shows 2 healthy pregnancies, those 2 bumps there. They have to moderate their vascular function through both of those events. But if they remain healthy, then that doesn't have a massive impact on their vascular dysfunction as they age. However, women who have hits to their vascular function, their kidney function during pregnancies, have a much increased rate of deterioration in vascular health, both cardiovascular and renal, of course. But we do have an opportunity to flatten those curves and bring things closer together, irrespective of pregnancy events. So if we optimize that postpartum care episode, we can really flatten the curve for those who have pregnancy complications like preeclampsia, sepsis, or a bleed. And these acute events that I've just described, so the main ones being sepsis, hypertensive disorders, and bleeding, aren't standalone events. So when these things happen in pregnancy, they do have significant long-term impact. So even an acute kidney injury associated with those things, which happens in this big Indian cohort in about 12% of pregnancies, up to 30% of those women, irrespective of renal recovery after the injury, will become dialysis dependent. Up to 51% will develop CKD, and up to 34% will die. So these are not standalone events. They do lead to chronic consequences. And that's true for the babies too. So we know that acute kidney events are associated with preeclampsia, with preterm birth, with low birth weight babies, and those infants are at significant increased risk of developing chronic kidney disease too. So we're not just thinking about the mum here, but we're also thinking about her baby. And indeed, in that woman who has known chronic kidney disease coming into pregnancy, the pregnancy itself is a acute event. So you can see from this graph, this is a study done, a review done by a group at King's that demonstrates for those with stage 3 or above chronic kidney disease, when they have a pregnancy, they will lose years of kidney function. And so I've summarized these data on the right-hand side there. So for someone who has a GFR loss during their pregnancy of 4.5 mils, that's equivalent to bringing dialysis or end-stage kidney disease 2.5 years closer. So for someone who enters a pregnancy with stage 4 or 5 CKD, that brings dialysis almost 5 years closer, or end-stage kidney disease 5 years closer. That certainly doesn't mean pregnancy isn't an option or shouldn't happen, but it means having pregnancies earlier in your CKD journey will reduce the impacts of that acute event on long-term deterioration. So after that short bit of pregnancy setting the scene, thinking about what we can do, why is it something that we should be thinking about? What is it? What opportunities might we miss if we're not thinking about kidney health carefully, or we're not thinking about pregnancy carefully when we're looking after women with chronic kidney disease? Well, the first thing is, and this is a busy slide, so excuse me for that, but there are significant, or I should say substantial physiological changes in kidney function during pregnancy that are laid out in this picture here. The ones I'll draw your attention to are perhaps some of those that we're familiar with, i.e. increasing protein leak through changes in tubular function, also that increased plasma expansion that we see in pregnancy due to those systemic changes in RAS and water retention. But perhaps most importantly, when we're thinking about kidney function assessment during pregnancy, it's this massive increase in renal blood flow and glomerular filtration rate, which you can see in the top right-hand box there under renal hemodynamics. So kidney function, as I've mentioned, massively increases to adapt to that increased blood volume, that increased vasculature, including the placenta and the baby. And with that, we see this pattern in change of GFR. So in the y-axis there, we've got glomerular filtration rate measured by inulin in this set of data. And then along the bottom, we've got time from 0 weeks, i.e. the point of conception, up to 44 weeks postpartum. And what we can see is that glomerular filtration rate increases through to the mid-trimester and then falls off towards term with a massive reduction postpartum back to about normal. And unsurprisingly, with those change in GFR, we see an inverse change in serum creatinine. So we see creatinine fall as pregnancy progresses, a slight increase postpartum after that hit of bleeding and fluid shifts that happen around the time of birth, with then a gradual decrease to around pre-pregnancy creatinine values. The thing I'll draw your attention to on this massive data set, which was it's Canadian data, but it's almost 250,000 measures of creatinine, is that the 95th centile, i.e. a creatinine that is above normal for the majority of women, is much lower than we often consider. So around 60 micromoles per litre in the mid-trimester, and around 80 at the point of delivery. I would suggest that might be lower than the thresholds that you're used to using. So we need to be careful about not underestimating the impact or the pathological relevance of a rise in creatinine. The problem with this data set is that these are all clinically indicated samples. So these samples were taken from people who had a risk of a kidney injury. We've repeated this, but on a prospective cohort of 644 women, and demonstrated actually that the normal range, the 95th centile for women who are perfectly healthy, is even lower than that which was described in that large data set. This is unpublished work, so I'd ask that you don't share it, but certainly feel free to reference it, and I'll let you know when it's published. But what we can see is that a creatinine above 53 micromoles per litre in an Asian group is likely to be above the 95th centile. So even that cutoff of 70 or 80 that we've talked about is likely to be high. So the reason I'm sharing all this is if we don't appropriately interpret creatinine as which is our current best gold standard measure of kidney function in pregnancy, then we can easily miss pathology. The other problem that we have is that acute kidney injury definitions, this is that from the KDIGO, are not valid in pregnancy. So they don't account for this change in physiology that happens to support a healthy pregnancy. So this rise of 26 micromoles per litre that we use to define a stage 1 acute kidney injury might well represent normal physiology if we're not interpreting it carefully. These, as I said, these definitions aren't valid in pregnancy. So we need to go back to basics and remember that an acute kidney injury, i.e. something that's happened to cause a dysfunction in kidneys, is anything that causes a change in kidney function that isn't reflected by physiology. So we need to go back to basics and think about risk assessment. To do that, we have to acknowledge what the common causes of acute kidney injury are for women who are pregnant, and they're up here on the slide. For those who are perhaps more less familiar with acute kidney injury, prerenal injuries tend to be things that are related to volume. So a lack of renal perfusion that causes a hit to the kidney's ability to do their job. So in pregnancy, that's often septic abortion, sepsis, prolific vomiting, or hemorrhage. A renal injury is something that impacts the endothelium normally, or indeed that acute necrosis of the tubules. And then a post-renal is an obstruction really of outflow of urine. So that might be pregnancy on its own, but it might also be a surgical injury, or indeed that obstruction of outflow of the urine from the bladder due to a kinked catheter even. So these are small problems that can cause big chronic problems if we don't address them. These things can happen, and again, a busy slide, but if you are at all interested in reading more about pregnancy AKI, I'd strongly recommend this paper in Nature Reviews Nephrology that was published earlier this year, and it really goes through best practice currently. So Kathy Nelson-Piercy, it was from a meeting that was held in India earlier last year. But what this diagram demonstrates is that acute kidney injury can happen at any stage of pregnancy. So we can't let our guard down whenever we see a rise in creatinine or an elevated creatinine or a reduction in urine output. If we're not in a position to measure creatinine, a reduction in urine output often will happen before the creatinine rises. So use our clinical nous to determine when there is a problem and have suspicion if we have any of these risk factors around. Acute kidney injury wasn't something that was part of my training. It wasn't something that was part of a lot of midwives training. It was irrespective of how common it is around the world. But I think that is starting to change, and it's changing because CKD is getting the stage it deserves in terms of its global prevalence and the avoidable nature of end-stage disease with early detection. And pregnancy acute kidney injury is also the majority of the time avoidable. Therefore, it's absolutely inappropriate for us to not be talking about it. It is avoidable, but it is also very high risk. So a woman who develops a pregnancy AKI has a 9 times increased risk of dying compared to a woman in exactly the same situation if she didn't have an AKI. And indeed, her risk of adverse pregnancy outcome goes up. The rates of acute kidney injury in pregnancy are increasing, irrespective of setting, but rates remain 30 times higher in low and middle income settings compared to high income settings. And that's because of that challenge around giving that antenatal care that allows early identification and also those barriers to transfer sometimes. But through improved midwifery care that allows early detection and the development of affordable treatments or implementation of affordable treatments, then we can mitigate some of these long-term consequences. I'm really aware that it's easy to say that we must intervene early, but that's not always possible when we're thinking about where we are. I would challenge you to think that actually there is always something we can do. So it's about that stacking of risks and thinking about avoiding these delays that we know are well described and getting the women who are at higher risk the earlier transport. and having acute kidney injury on your radar as something that does warrant transport, does warrant transfer. So I think it's just about considering acute kidney injury, noticing that deterioration in urine output and that rise in creatinine if possible, and getting women moving sooner, as well as responding to those three primary causes of acute kidney injury: hemorrhage, sepsis, and hypertensive disorders, in the way that we all know we can. I've touched on this, but pregnancy AKI, acute kidney injury, really can be viewed as this stacking of risk. And there are certain things at the bottom here that we can't mitigate for. But as we go up this tower, there are things there that we certainly can do a good job of mitigating. I.e., noticing someone who has a previous AKI, or who is starting to bleed, or is vomiting too much, and taking those early actions, diagnosing the hypertension, using valid devices if at all possible, and then noticing those risk events or those trigger events, which I've noted here with the alarm clocks, that warrant that immediate action. So it's really remembering that stacking of risk and looking at that woman who's in front of you and thinking holistically about what we need to do for her. So we've talked about what we might miss, but let's also talk about that long-term risk. So what does the evidence tell us that might happen for these women after they've had an acute kidney injury? And this is something that's important to think about when we're counselling women, when they're planning their postpartum follow-up, and also when we're talking to them before pregnancy, if we know they have CKD, to think about what their risk of this individual pregnancy is. So the first thing really is to emphasize that preeclampsia on its own is a risk factor for chronic kidney disease. So if you see someone who has had a previous preeclampsia, and I'm sure this is stuff that you guys are so familiar with, but if you see someone who has preeclampsia, it's very important that they get their kidney function checked, either just knowing to monitor their urine output, knowing to dip for protein, knowing to have their blood pressure checked. These are relatively simple tests to offer in community settings if we can. So it's about facilitating that follow-up so that we can pick up those women post preeclampsia and implement those lifestyle changes that can reduce that risk of chronic kidney disease. Preeclampsia is also a risk factor for acute kidney injury. And as I've said, the women 15% of women, this is in an African cohort, who develop preeclampsia had acute kidney injury. And of those, there was a significantly higher risk of death, intensive care admission, and stillbirth. But the biggest predictor was hypertension in a previous pregnancy. So if someone's coming into a subsequent pregnancy, so their second, third, fourth pregnancy, and they've had a previous hypertensive pregnancy, talk to them about monitoring their urine output. Try and check their blood pressure as regularly as possible. Try and dip for protein. Try and take their creatinine if you can, because these are the highest risk women. But it's a vicious circle, because once you've had an AKI, your risk of preeclampsia is higher as well. So yes, preeclampsia increases your risk of acute kidney injury. Preeclampsia increases your risk of chronic kidney disease. But also, chronic kidney disease and acute kidney injury increase your risk of preeclampsia, which you can see in the top of this graph here. And the worse the previous acute kidney injury, the more likely you are to develop preeclampsia. But again, it's not just risks for the mum, but it's also risks for the baby. So a previous AKI increases the risk of preterm delivery, small for gestational age, neonatal intensive care admission. If we look at these babies who have the bad outcomes, it's the same three risk factors that are most strongly associated. So preeclampsia, sepsis, and hemorrhage. So these are predictive of those babies who are going to be born small or early, who then end up having that chronic kidney disease. So it really is a vicious cycle. So just to demonstrate that cycle, we have this mum who has CKD, who has a pregnancy. She has a higher risk of premature birth. So she has an infant with reduced nephron number, because nephrons continue to be developed till at least 36 weeks. So then that infant grows up with high risk of CKD, and so on. So if we can cut this cycle by reducing the risk of premature birth, by avoiding the preeclampsia for the women with CKD, by offering the early aspirin if possible, by offering the good monitoring during her pregnancy and early antihypertensive therapy, then we can try and reduce that risk of premature birth and of course reduce the risk of acute kidney injury on top of the CKD. For those women who do get pregnancy AKI, I'm painting a very bleak picture, but I promise I will tell you the solution soon. There is also this significant risk of long-term complications. So for a woman who's had a pregnancy AKI, they have a 22 times increased risk of heart failure, a 23 times increased risk of stroke, and an almost 10 times increased risk of peripheral vascular disease. This is a massive systematic review that was done, published earlier this year in the British Journal of Obstetrics and Gynecology. Again, another really good review to read if you want to understand this, a bit more about this sort of long-term risk of pregnancy AKI. But this is irrespective of recovery of kidney function postpartum. That recovery is really important to monitor for. So if you have someone with that reduced urine output or with evidence of an acute kidney injury around the time of birth, it's really important that we confirm recovery, but expect that there will be a proportion of women who don't recover their kidney function. So those who had a stage 3 AKI in this African cohort, 34% did not recover their kidney function. So they would need to be referred into a for renal follow-up for management of that, if at all possible. And this assessment, ideally, postpartum, is a urine dip for protein and blood and a test of creatinine and a blood pressure. But of course, it's whatever of those 3 pieces of information we can get together. I needed to share this quickly. This is a student who did her master's with us at King's just earlier this year from Indonesia. So she came over to King's to do her MSc, and she did a global evaluation of the barriers and facilitators to identification and management of pregnancy AKI. So I'll say thank you to Nabila for sharing her slides here. But we did a survey and we got 1,300 responses, and we reached 79 countries around the world, which we were really, really pleased with. Again, busy slides, apologies, but if I just draw your attention to the tables on the right-hand side there, the red is low knowledge, orange is moderate knowledge, and green is high knowledge. And the thing that I would suggest is it's interesting that the level of knowledge in high income settings for doctors and for midwives, actually the level of high knowledge is lower than it is in other income settings because we don't see it. So people in low and middle income settings where acute kidney injury is 30 times more likely, the rate is 30 times higher, you guys are the experts. So we really need to be doing this South-North learning so that we can work together to do better for these women. There are, of course, barriers in terms of resource. So there was very clear indication that it's not always easy to get serum creatinine results, and that was harder the less resource you had, which is obviously expected. So we need to think carefully and laterally about how we expect people to, or how we recommend people assess for kidney function. So enough of the sort of laying the scene as to how hard things are, but let's have a quick chat about what good care might look like, what we could do. The first thing is, and this is tricky, but women with chronic kidney disease really benefit from having coordinated care. So having nephrology input, if at all possible, having obstetric input, and having good midwifery continuity of care. Those 3 things together have been demonstrated to improve outcomes. So with that circle on the right-hand side demonstrates the cocoon model of care. And for women with chronic conditions, we know that that cocoon model is really important. And we also need to start thinking cleverly about the devices that we're using to monitor these women. So devices that are valid, that are cheap, that don't rely on refrigeration, and that ideally don't require network. So this is what we're working on in a lot of our research, to try and facilitate this sort of pattern of care, but using devices that are available and usable. perhaps the most important thing, particularly for any nephrologists on the call or any obstetricians and gynecologists who see women earlier in their fertility journey, the preconception conversation cannot be overemphasized. If we can improve hypertension, if we can reduce proteinuria before women get pregnant, then and improve those lifestyle choices, then they're less likely to have the acute kidney injury. Therefore, we stop that cycle from before she's even pregnant. So that preconception conversation is just crucial. The other thing is that proteinuria on its own is massively important. So a dipstick for proteinuria is the best indicator for severe maternal morbidity and preterm delivery. So these are from a piece of research that was done a couple of years ago, and it demonstrated that the more severe the proteinuria was, even with relatively normal kidney function, the outcomes were worse. So if we can't check creatinine, if we can't check a lab-based test, if we can even just dip for protein, then it gives us a good idea of how to risk stratify. And the other thing is have guidelines, have things written that help us remember how to act. So this is something that our group put together based on a co-design with women, with care professionals across our CRIBS Global group. So Africa, Asia, India, and the UK. And this was a response to acute kidney injury. So if someone had a creatinine above 80 or had a low urine output for 2 hours or more, then this is the advice that we would give. So good initial observation. So ISTOP being the acronym. And I'm very happy to share these things afterwards. And indeed, you can access them on our Global Pregnancy Acute Kidney Injury website. Start the treatment for the cause. Our 3 common causes there again. Avoid making the situation worse through giving toxins. Optimize fluid status, and this is an absolute key one. I keep talking about reduced urine output. We need to rehydrate if they are truly dry, but we also need to not overhydrate if those women are having fluid shifts in the wrong directions. And then we need to prevent and monitor. So something like this stuck on your wall in your high dependency or in your admission area or in your peripheral clinic to help us know when to escalate is a useful tool. These are really old data from back in 1996, but it's just still a really good graph, and all subsequent data sets have demonstrated the same, that for women who have chronic kidney disease, they can be stable. So this is demonstrating glomerular filtration rate during pregnancy on the left-hand side, and then from 6 months from pregnancy to 6 months postpartum on the right-hand side. And you can see that women's glomerular filtration rate declined in 31% of women, even postpartum, even when it had been stable in pregnancy. So we need to be really cautious that we're not falsely reassured by a woman who's been stable through her pregnancy and keep monitoring her postpartum. I think one thing that we can't not talk about is this big policy shift to enable midwives to offer that true continuity of care for women with chronic conditions as well as women who are healthy. And when we do have midwives who are educated, who are able to offer this true survive, thrive, transform models of care, then we can have a significant impact. And midwives are so well placed to reduce acute kidney injury because of those early signs that it will be the midwife who is bedside that will pick up, i.e. the fall in urine output, the change in confusion state, things that might be very subtle to start with, the slight rise in blood pressure before you've reached a trigger warning. So midwives are best placed to be the people who acknowledge these acute changes. So now, what could we do from today? So given what we know already, what could teams implement from tomorrow? Well, the first thing I can't avoid but say is don't exclude women from research. There is such a bias against women being represented in clinical trials, and in CKD it's one of the worst, actually, particularly pregnant women. So we need to not exclude women. Exclusion isn't protection. So making sure that we're including women in trials with appropriate mitigations is really important. The second thing is using the most up-to-date evidence. We've recently established this Global Pregnancy Acute Kidney Injury Consortium, and we're working hard to present data in a way that is easy for institutions and for practitioners to access and change their practice in response to. So this is a statement that will be coming out soon that we think is going to be endorsed by the International Society of Nephrology, FIGO, the International Federation of Midwives, that will say that a serum creatinine above 77 should trigger investigations. So we need to be using this best practice evidence. I put a QR code there for our website. We'll be working really hard to keep that up to date. And again, I can share links in the chat perhaps, but please do access the most up-to-date evidence and make sure what you're doing, what you're basing your decisions on are up to date. This is that paper that I mentioned earlier, Kathy Nelson-Piercy's paper. These are some examples of the way that this paper has laid out best practice currently, and I would really urge you to present this to those who are in charge of guideline writing or indeed in charge of decisions about transfers and access to care, because this really helps understand those risk factors and the current best evidence, and was written on a global consensus where there wasn't good evidence. So please use that to your best ability. The other thing I would urge you to do is to remember it doesn't have to be complicated. So as part of our survey for our global survey on the barriers to diagnosis and management of AKI, we realized that we asked people to send in photos of the vessels that they were using to measure urine output. And the most common by far was things like that top right picture there, so cut-off water bottles. And of course, there's a problem around dignity, asking women to measure their urine in vessels like this. But if we can use this information to acknowledge when someone's deteriorating and get them access to dialysis for a few days to protect their kidney function, to then take them off dialysis so they don't, because they haven't developed the chronic kidney disease, then I would suggest it's worth it. So to all midwives on the call, I urge you to practice good fluid management through accurate fluid balance. Scribble it on a piece of paper, whatever, but have that on autonomy. The use of point of care testing, and of course this is a bigger decision, but for people offering services, placental growth factor testing to screen for preeclampsia, also point of care devices, which is this epoch on the right hand side for serum creatinine, are becoming much more affordable, and we're doing a lot of work to try and get these out to units. So if you don't have facility for serum testing for PLGF or for creatinine, these are now available. We're going to start working on a global snapshot of pregnancy AKI through the consortium, and we would love to reach out to any sites that could collect data on that. And the last thing that I put at the bottom left there is don't forget your basic clinical bedside skills. So to understand if someone is fluid deplete, who will respond to a fluid bolus, either oral or IV, we can do basic things like a passive leg lift that shoves 300 mils of blood back into their central system. Even if we can only palpate pulse, if we're feeling an increase in pulse pressure with that passive leg raise, then we will notice that they are likely to be fluid responsive. That blood pressure device that I showed is something that our group has managed to get, which had the worst maternal death rates. And just by implementing a good validated blood pressure device, we've demonstrated a 60% reduction in maternal death and a 40% reduction in eclampsia. So the implementation doesn't have to be complicated. Stick to the simple stuff first. And don't forget to screen the babies. We can pick up this evidence of early kidney dysfunction in those newborn babies who have been born preterm, low birth weight, of mothers with preeclampsia. And the final thing I'll say is don't forget to have a life course view. So a woman who's coming into pregnancy has had life before that, and a woman you're looking after in your kidney clinics further down the line has had a pregnancy. So don't forget to think about pregnancy as part of this life course and those the impact of all those events on subsequent pregnancies. Using that life course approach, we can prevent acute kidney injury, we can recognize it early, take action, keep monitoring, and remember to treat women as individuals throughout. This is an example of some of the things you can expect from the pregnancy, the AKI consortium. We're developing a really broad toolkit, so keep an eye on our website. And my final call is, would you be willing to make a pledge to say that you will go back to your institution and check if you have a guideline on pregnancy, acute kidney injury, or even fluid management? Are you screening for it in women with hypertension, sepsis, and hemorrhage? And if you're happy to make that pledge, to take that responsibility, then again, I'll share this QR code as well. Our final website, and thank you so much.
Wow, thank you very much, Catherine. It's very, very insightful information. As you know that in Indonesia, our the top 3 of the causes of the maternal mortality is preeclampsia. And now we know that we can prevent the preeclampsia by uh, controlling the prevent by the kidney health. It will be decrease everything in if we can prevent in the very beginning step. But unluckily in Indonesia we didn't like have a point to prevent the kidney health in pregnancy. But this is very insightful information, and we cannot wait to use it in Indonesia, because in Indonesia we still have like in primary healthcare, or we call it puskesmas in Indonesia, we have the guideline. If the mother want to have deliver the baby in the first time, or maybe when they have the uh, delivery process, before they come into the labor room, they have to test the protein urine, but it's still very limited in protein urine. It's not about a whole kidney health like that. So thank you very much for the insight presentation. Now we will move to the Q&A session. For every participant that have a question for you can type it on the chat box, and I will help to read the question. So we already have one question from Ifa. She is one of our student of postgraduate program for nursing, and here we go. I am Ifah Kurniawati, a graduate nursing student at Poltekkes Semarang. My topic focuses on women with preeclampsia and the management strategies needed to prevent progression to chronic kidney disease. Hypertension that occurs during pregnancy often continues postpartum and may develop into long-term renal complication if not properly managed. Yes, so Ifah Kurniawati sharing about her thesis, I think. So what do you think about this?
Yeah, I think it's an absolutely crucial part of the jigsaw, and indeed the postpartum window offers the best time to optimize. We are just starting a project in Zambia, Sierra Leone, and South Africa, looking at community-based interventions for women who've had hypertensive disorders of pregnancy, including preeclampsia. And the intervention includes, the first part of the project is to design the intervention, but what we think it will include is salt reduction. It will include treatment of the hypertension where possible. It will include community champions who will help monitor and help empower women to make good health choices, perhaps where they're not supported to do that through their communities. So I think with that postpartum intervention, we really can think laterally about what good looks like. And if I'd be so happy to have a chat with you about that project and think if there's any collaboration that we could do together, because it sounds like we're working in a very similar space.
Wow, okay, that's great. So, Ifah Kurniawati, maybe you can just directly contact Catherine to discuss about your project. She is very welcome about it. And while we are waiting for the participant that maybe want to asking a question, and maybe I want to discuss about the thing that maybe we already discussed, that nowadays in Poltekkes Kemenkes Semarang, we are as a center of the development of the kidney health in the education. So in our curriculum, we already have one subject in Diploma 3 of midwifery. So it subject is about maternal and child kidney health, but actually we are not really have this typical detail of the how the undergraduate student can prevent or what can the undergraduate student can learn in the class, so after the graduate can be prepared to continue what they have to do to more specifically think about what the mothers need. It's about to taking care of the kidney health while they are in pregnant session like that. So what do you think about this?
Yeah, I think you guys are ahead of the game to even have any kidney health in midwifery education. So I think you should be proud of what you do have rather than feel bad about what you don't have. The thing that I'm excited about is, as part of the consortium, we would like to put together a example curriculum for undergraduate and postgraduate midwives, and nurses and doctors, but obviously midwifery being the focus. So we have some collaborators from Zambia in Lusaka who are working on this. But if there was a couple of people from your faculty who would be interested in joining that group, then we could work together to define what good looked like. And again, the International Confederation of Midwives are really keen to work with us on that. So perhaps we could do it as a team effort rather than each be working on the same thing separately. So I'm very excited. It sounds like you guys are ahead of the game. So please, let's work together on that too.
Yes, please. I want to do that too. And I think it's like a finding a very precious thing that I can find. We can find you, and we now already know what or who will be contact about this specification of maternal and child kidney health. So I think this
Back
is
at you. Yeah.
yeah, and it still have a connection with the last question for my question. So we have more question from Ibu Dr. Sri Sumarni. She's one of senior lecturer from Poltekkes Kemenkes Semarang. So she asking about what do you prepare what your midwifery students at school in antenatal subject major for preventing eclampsia and long-term CKD?
Yeah, thank you. Thank you for the question. So again, I think it's about remembering the physiology and the pathophysiology and acknowledging so the things that we teach are about that health optimization pre-conception, the early screening, and a really good risk assessment. So acknowledging that family history, previous pregnancy history, existing hypertension, existing proteinuria are all really important, as well as other sort of location-specific risk factors are really important for your risk assessment. And then using those to implement aspirin as your one and only real prevention for preeclampsia. And then thinking about the eclampsia piece, it's about the early identification and again acknowledging deterioration and risk early. The long-term CKD, we really emphasize on, again, that risk stratification at the point of discharge postpartum so that you can make sure women get their good follow-up, but also good intrapartum care with good fluid management. And I cannot overemphasize the importance of fluid management and fluid balance and going back to basics, either encouraging fluid in terms of oral hydration or not. So the prevention of long-term CKD, really, we focus on good intrapartum care management, risk assessment, and then postpartum follow-up. But again, that was a very brief brief answer to a very good question. So we can, yeah, we'd also love to learn from you.
Okay. Thank you very much, Catherine. And as you know, that we still learn about it too. We didn't see any in the will be great that if we can continue. Okay, sorry. Check. 1, 2, 3.
Yeah, okay. It's
One,
clear.
I can hear you now.
Okay, okay. Am I audible?
Yeah.
Okay. Yeah, I think this is a very good chance that maybe we can do a collaboration in the next project, because you say that you already done it in Zambia and other country, maybe Indonesia will be next country that maybe we can use this tool. It's very incredible tool. It didn't need like complicated tools, and hopefully it will be beneficent for Indonesia for decreasing the maternal and mortality death in Indonesia. So is there any question from the participants? Okay, so I think that's enough, Catherine. Thank you very much for your very lovely, insightful presentation, and hopefully we can meet again and have another collaboration. Thank you very much,
Lovely. Thank you so much.
Thank you very much. See you on the next time. Thank you.
Thank you.
So over to MC. Thank you very much for the opportunity. Thank you, Catherine. Thank you very much.
Okay, thank you very much, Mbak MC. But I think the signal in your fourth floor is not clear enough. I think you need to check it. Yeah, the noise is on off. The sound is on off. Okay, thank you. Yeah. Okay, thank you, MC. Hi, Prof.
Hello, good morning.
Good morning, good afternoon. Yes, how are you, Prof?
Very good, very good.
You look so bright.
Oh, it's all winter here.
Yeah. Hi, how is the political situation in Nepal?
It's all good now, all
Good
settled.
now?
Yeah.
Yeah, thanks to God. Yeah, one of my colleagues, the moderator before this session, Miss Teki, wasn't there. Wasn't there when the demonstration is occurred. She was in there with WHO.
Yeah.
W.
Namaste.
Mbak
Prof.
Teki.
Asha Tapa.
Namaste.
Yeah,
Namaste.
Mbak Teki is there, but I think everything is good ya, Mbak Teki ya.
Yes, and
Yes,
we'll back again at December, inshallah.
yeah. Oh, back there again? Yeah. I
Yes.
will join you. Prof.
Yes, please.
Asa. Okay, Prof. Thank you very much. Before I read your CV, I would like to say good afternoon for distinguished guests, esteemed speakers, respected participants, ladies and gentlemen. It is my profound honor and pleasure to welcome all of you to the 8th International Conference on Handling Non-Communicable Disease. My name is Professor Diah Fatmasari, and I will have the privilege of serving as your moderator for this session. My role today is to get our discussion, ensure a smooth flow of ideas and facilitate meaningful exchange between our panel and all of you. This is Prof. Asa. Yeah, Prof. Asa and me actually a bestie. In Indonesia, it's called bestie, Prof. Sisters. Yeah, sister, because we have a very wonderful event in Chiang Mai, yeah, Prof. Almost
That's
10 days, yeah, Prof. Yeah, we have occasion about oral health care in primary care settings in Chiang Mai hospitals. And I know her very much. She is very kind, very beautiful, and also very
thank you.
smart and this. Yeah, Prof. For it's around 1 hour. Yes, maximal 1 hour, Prof. You can present your presentation. I already read your PPT. It's very comprehensive presentation, Prof. Yeah, and then I believe that the participants include dentists and also dental therapists and also another health professionals will have very insight material about yours. Before you present your PPT, Prof, I will read briefly your curriculum vitae. Yes, Professor Dr. Asha Tapa, she is from Kathmandu, Nepal. Yes, next. And professional summary, yeah. And the current position and professional summary, Prof. Asa now is member secretary of Medical Education and Curriculum Committee and AMS. You took your professor in conservative dentistry and endodontic in 2023. Yeah, Prof. I took my professor in 2020, Prof. And senior consultant also for dental surgeon. And also for, yeah, I believe you active in the publishing, yeah. Yes, editor of postgraduate medical journals and editor for Journal of Nepal Dental Association. Okay, next for academic qualification. Prof. Asa finished for school living certificate in 1998, etc. until MDS, conservative dentistry and endodontics. Is a specialist, Prof. Yeah. MDS is Master Dental Science in Specialist Conservative Dentistry and Endodontic. And also next professional experience is a lot of next in peer hospital. Okay, next, and also teaching and academic roles. Yeah, there's so many, and research and publication is so many publication. The last one is publication in what year, Prof? 2023. Is there any publication in 2024, Prof? Maybe I believe you already have also. Tapa Asha about the compression of post-operative pain after single visit root canal filling using resin-based sealer and bioceramic sealer. Okay, Prof, that's your CV, workshop, seminar, professional memberships. I believe you very active in Nepal. Okay, Prof. Next for the presentation, Prof. Your material, share by yourself or by the committee, Prof.
I'll prefer to share myself. Is it okay?
It's okay, Prof. Okay,
Okay.
Prof. Asa. So on the Zoom, next is yours, Prof.
Thank you so much. Thank you so much, dear.
Yes.
Okay. Let me share my screen.
फुल प्रोजेक्ट करते हैं इसमें
It's visible?
It's okay, clear.
Okay. Okay, thank you, Professor Dia, my dear friend. Before I start with my topic, I'd like to thank the 8th International Conference on Handling Non-Communicable Disease, the organizing committee, and my special thanks to my friend, Professor Dia Fatmasari, for giving me this opportunity. So, hello and namaste, everyone. Thank you for that nice introduction. Yes, it's like I am trying my best to do something in dental field in Nepal. So let's start with the before I start the topic, I'd like to introduce my country. So namaste everyone once again. This is Nepal. It is a small country land. It is a small country located between China and Nepal. But it is very versatile and very diverse in terms of geography and culture and climate. We have different regions. The mountain region consists of snow-capped mountains, and then we have hills and valleys in hilly region and flat Tarai region. So the climate here also varies from alpine climate to tropical climate. And these are the 8 of the 14th highest peaks of the world. They are situated in Nepal, including the tallest one, the Mount Everest. This is just a few pictures of how showing the diverse culture of Nepalese people. Very colorful. So this is the place where I work, National Academy of Medical Sciences, Bir Hospital, Kathmandu, Nepal. It is a central government hospital located in Kathmandu and also an academic institute where we teach bachelor level to master's and postmaster's level in various fields of medicine, dentistry, as well as paramedics. In dentistry, we teach residents, master's level residents in different specialities of dentistry. So that's about my country and my working place. So let's start with the content. I'll be dividing my presentation in this contents. Firstly, I'll give a brief background about the oral health and NCDs. Then I'll discuss about the bidirectional relationship between kidney disease and oral health, where I'll be discussing why oral health matters in kidney disease and why kidney disease matters in oral health. Then I'll discuss about few of the oral health strategies which are very important for overall health and benefit of the patient care. So starting with what is oral health, since it is a mixed crowd, my audience are mixed from dental and non-dental background, I have make a very simple presentation. So oral health, as defined by FTI World Dental Federation, is multifaceted and includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expression with confidence and without pain, discomfort, and disease of craniofacial complex. So oral health is more than a beautiful smile. It means having healthy oral and perioral structures, which include teeth, gums, lips, tongue, salivary gland, hard and soft palate, mouth, throat lining, etc. Good oral health is essential in our daily life, from eating, breathing, and speaking to overall health and well-being of ourselves. Why it is important? Because it touches every aspect of our lives, may it be physical, may it be social or emotional. Also, oral health, our mouth is a window into the health of our body. How? Because many of the systemic diseases and conditions show their oral signs and symptoms, and often a dentist or oral health specialist become a first person to lead to the diagnosis of many systemic illness. This oral systemic link is evident and increasingly being researched. Many studies have connected oral diseases with other systemic NCDs based on spatially molecular and immunological based evidences. Hence, from 2011 United Nations High-Level Meeting on NCD, oral diseases and oral health is increasingly being promoted as a part of spectrum of NCDs. Coming to oral diseases, they are the most common NCDs worldwide. Almost half of the world population suffer from oral diseases. And among the oral diseases also, the most prevalent one are dental caries, periodontal disease, and oral cancer. Pain and discomfort are the common complaints of the patient, which leads to difficulty in concentration, missed school and work, social isolation, and if left untreated, it can lead to severe complication. However, oral diseases are largely preventable, and if they are diagnosed early and treated early, they can be treated using simple and non-invasive technique even at primary healthcare centers. But if the treatment is delayed, it will become more expensive and complicated. Different studies have established a relationship of systemic conditions like cardiovascular disease, diabetes mellitus, pulmonary diseases, and chronic kidney disease with oral diseases, mainly the periodontitis or the periodontal disease. And however, the link found is more of association, not a causation. And in some situation, even a bidirectional model has been observed. For example, in cardiovascular disease, diabetes mellitus, and even in chronic kidney diseases. Now, what is this periodontal disease or periodontitis? Periodontitis is a chronic inflammatory disease that affects the supporting structure of the teeth, including the gums, periodontal ligament, and the alveolar bone. It is a key contributor to oral and systemic health. And the main causative agent behind this is dental plaque, which is a biofilm, bacterial biofilm adherent to the tooth surface, which if not removed properly with oral hygiene habits, it will lead to gingival inflammation, and which further progresses into different stages of periodontal diseases. Finally, may lead to loss of tooth if not treated. So in this picture, the above picture, you can see that there is a very bad oral hygiene with a lot of calculus and bleeding gingiva, inflamed gingiva, you can notice there. And in the picture below, you can see how healthy gums are, the pink gingiva, the very firm and periodontal ligament which is attaching the tooth to the tooth structure firmly. Whereas in case of periodontal diseases, the gingiva will be more of inflamed and red, and the periodontal attachment will be lost, and even the bone height will be reduced. So periodontitis doesn't only lead to the oral complication. It is also found that in case of periodontitis patient, there is increased systemic inflammatory markers, especially inflammatory markers like C-reactive protein and interleukin 6, so which can lead to many systemic diseases, especially non-communicable ones. So this dual impact of periodontitis on oral health and systemic diseases, this demands a collaborative effort between the dental team and the medical team for the holistic care of the patient. So let's start with our topic, oral health and kidney diseases, which are found to have a bidirectional relationship. So brief introduction about chronic kidney diseases. It's abnormalities of kidney structure or function present for more than 3 months with the implication for health. And it is found that over 10% of the world population suffer from it, and it is a major socio-economical and healthcare problem and a leading cause of mortality worldwide. It is predicted that it will become the fifth cause of death by 2040. Hence, it is high time for us to control the modifiable risk factor for chronic kidney disease. One of them is periodontitis. So it is very important to understand the relationship for overall patient care. So to understand the relationship, let us understand first why oral health matters in CKD. Both CKD and periodontitis they share common features like both are non-communicable disease, and they share common risk factors like age, gender, ethnicity, socioeconomic status, smoking status, hyperglycemia, and obesity. And this flowchart describes the impact of periodontal disease in pathogenesis of chronic kidney diseases. So periodontitis can lead to bacteremia, and also the inflammatory products into the circulation, which can lead to inflammation of the organs other than periodontal lesion. And this can lead to various disease processes by various pathological mechanisms like renal fibrosis, hypertension, diabetes, liver disease, gut microbiota alteration, etc., which can lead to chronic kidney disease, which are the important risk factors for chronic kidney disease. So I'd like to highlight few studies here, few research in the field of periodontitis and chronic kidney diseases. So let's go through their conclusion. Sharma et al. In 2021 have found out that 10% increase in periodontitis results in 3% decrease in renal function, and 10% decrease in renal function resulted in 25% increase in periodontitis. So this is a circle of event. Also, it is found in a systemic review and meta-analysis by Cerny et al. That periodontitis is a frequent comorbidity associated with chronic kidney disease, and various studies have found a range between 34% to 93%. Not only in pre-dialysis patient, but also in hemodialysis patient, they are associated with higher prevalence of severe periodontitis compared with the healthy individuals. Oral diseases including periodontitis, because the patient are unable to eat properly, so it also impact in nutrition status of dialysis and pre-dialysis patients. Not only in dialysis patient, but also in kidney transplant patient, poor oral health has found to have a negative effect in transplant outcome and quality of life. Studies have found that periodontitis increases the morbidity and mortality in chronic kidney diseases. But there is a solution, because since periodontal disease are treatable, so treatment of periodontitis improves chronic kidney disease status by reducing the systemic inflammation. However, the treatment in CKD patient is more difficult because of the pathogenic subgingival microbiota that tends to persist after the periodontal treatment. So it requires multiple visit and regular follow-up. This is a diagram I've taken from net, which shows a cycle between a periodontal disease and CKD, and the mechanism to break this cycle is the proper oral hygiene habit and the treatment of periodontal diseases. However, cross-sectional studies from Spain and Netherlands reported that they did not find any significant association between chronic kidney disease and periodontal disease. So one of the reason may be because they have said is because these studies are from developed countries which have a strict oral hygiene protocol there, and it is because of the fact that dental treatment is a part of their routine therapy. So the reason associated may be this. This highlights the importance of oral hygiene maintenance as well. Looking at this studies and research, we can conclude that the need of an hour is to integrate the comprehensive oral screening at diagnosis and pre-dialysis level in kidney unit. Also, it is very important to rule out and remove all the sources of oral infection in the patients, and regular oral hygiene reinforcement is very important, as well as regular dental follow-up every 3 to 6 monthly is very important in these patients. So these were about the relationship of oral health and chronic kidney disease. So also chronic kidney disease matters in oral health. How? Let's know about this also. So chronic kidney disease predisposes to a high risk of oral diseases, up to 90% higher than general population. Like many other systemic diseases, chronic kidney diseases also have oral manifestation. So these oral manifestations are related to the alterations in kidney function related to CKD. So these are mainly xerostomia, uremic halitosis, uremic mucositis, alveolar bone loss, etc., which are related to increased urea and uremic toxin levels in saliva. Paleness of gingival mucosa related to normochromic and normocytic anemia related to the disease process. In children, especially in the children, enamel hypoplasia is found, and also increased susceptibility to tooth decay, and demineralization of alveolar bone, fracture of jaw, abnormal bone healing after the tooth extraction, and also tooth mobility are some of the major complications related to calcium phosphorus metabolism impairment. Uremic gastritis can lead to oral lesions and dental caries, and it is also found that chronic low-grade inflammation and oxidative stress make high risk to, it leads to high developed periodontal disease. And as I have already mentioned that many a times, this is a study from Indonesia. So many a times the dentist become the first one to diagnose the kidney disease through oral symptoms. So that was about the symptoms in pre-dialysis phase, and also in renal replacement therapy, there are some signs and oral signs and symptoms that can be noticed, like for in hemodialysis patient, they are at high risk of spontaneous gingival bleeding, petechiae, and bruising. And also they are found to have coated tongue, which is related to mainly the poor oral hygiene and restricted fluid intake. They are at higher risk of viral hepatitis and HIV, which may also show their oral signs and symptoms. In case of renal transplant patient, they are at higher risk of gingival enlargement associated to the medication, especially the cyclosporin and nifedipine. Also, because of the long-term immunosuppression, they are at risk of getting candidal infection and various viral infection like cytomegalovirus. And also it has been found that renal transplant patients are at high risk of getting oral malignancies like oral lymphomas and squamous cell carcinoma. So these are the alteration in oral health that can be seen in chronic kidney patient. Also, we need to alter, as an oral health professional and dentist, we need to alter our treatment in CKD patient. So major things we should consider while treating the CKD patients are like we should always take consultation with nephrologists to determine the stage of renal disease, regimen for medical management, and alteration in oral treatment if anything is needed. It is very important to monitor the blood pressure, hemostatic and hematocrit values before the treatment, and also blood urea nitrogen and serum creatinine level, because if it is at the higher level, we may have to stop the electric dental treatment. We won't be able to give it. Also, we should avoid or do the dose adjustment of many medications and nephrotoxic drugs. And we should avoid NSAIDs, which are regularly prescribed for dental pain, and rather replace them with acetaminophen. Also, as the recent the recent guidelines doesn't suggest for the antibiotic prophylaxis, but it is always best to consult with the nephrologist for requirement of any antibiotic prophylaxis in this patient. Treatment alteration in hemodialysis patient are like as they are in heparin anticoagulation. So we need to perform the dental treatment not on the day of hemodialysis. Especially it is recommended to do the treatment 24 hours following the hemodialysis procedure so that there is no heparin in the blood. As they have a vascular access for hemodialysis, it is better to avoid the compression on the arms with vascular access while sitting in the dental chair, and never use it to measure the blood pressure or administering the drugs intravenously. Since they are at high risk of renal osteodystrophy secondary to hyperparathyroidism, it is better to do the dental extraction and other procedure very carefully, because they are at high risk of bone fracture. Since these patients are on long-standing corticosteroid therapy, there is a risk of adrenal crisis. So it is always better to give them morning appointments and consider the need for supplemental corticosteroid. And it is common to have a gingival overgrowth, as I have already shown the picture in this patient. So if the medication cannot be exchanged with other medication, then we have to consider surgical treatment in these patients. I hope I have made clear the relationship between chronic kidney disease and oral diseases. So few strategies I have made here, I have pointed out for the interdisciplinary collaborations between the kidney unit and oral health unit. There is the interdisciplinary collaboration team, consists of the nephrology team, dental team, and other teams like dietitian, psychologist, or social worker, and also different comorbidity specialists as per the need of the patient. So we have to work in collaboration during the oral management. The main goal of the collaboration is a regular communication and coordination between the team. So the communication pathway may be the integrated health information management system, if you have one in your country, or we can use share electronic health records or referral forms. There should be the documentation of renal disease stage, dialysis schedule, medications, blood reports, oral health status, treatment needs, different undergoing oral treatments, follow-ups, home cares, and comorbidities also should be mentioned there, and diet information. So the role of collaboration is early diagnosis, patient education, treatment planning, long-term planning, and knowledge and information sharing, and research and public awareness. So these are the various strategies for oral health care. Let's go through them one by one. Strategy 1 is early diagnosis. This can be accomplished by integrating comprehensive oral screening at diagnosis and pre-dialysis level in kidney patients. So which can be accomplished by thorough history taking on oral hygiene habit. If they have any deleterious oral habits like smoking and chewing tobacco, that also has to be asked, and also take history of pain and discomfort in the oral cavity. We need to have a thorough oral examination and periodontal examination of these patients to rule out any sources of infection in the mouth. This can be done by any trained staff in the kidney team or a dentist or the oral hygienist. If they have, it is better to have them in the nephro team. Also, if you have a dental unit in your hospital, it is better to refer the patient for dental consultation. And for all early diagnosis, it is also important to integrate the assessment of chronic kidney disease in a routine oral screening as well. The second important thing is patient education. So this can be, so it includes the education to the patient regarding the bidirectional link between oral and kidney health. They should be made clear about this relationship. And we should train them on oral hygiene practices, proper oral hygiene methodologies. We should inform them about the xerostomia and the care needed for the xerostomia, like prescribing them the free sugar-free chewing gums or artificial saliva as per the need. They should be highlighted the importance of routine dental visit. Also, if they have a tobacco habit, tobacco cessation program should be installed. Diet counseling is also important, and they should be informed about the risk of sugary foods, and we should request them to avoid them. Also, we should refer them for psychosocial counseling if to counteract the stress related to chronic health diseases if required. So after patient education regarding the treatment planning also, we should work together. Like the treatment planning should be individualized treatment plan based on individual patient need, like age, stage of kidney diseases, type of replacement therapy, medications, oral treatment need, hemostatic and hematocrit values need to be considered. And we have to consider the timing, as already explained before, the importance of dental appointment timing in these patients. Other things we need to consider during treatment planning is if they are having any medications. So that medication associated oral problems should be considered and should be taken into considerations. Also, if any oral medicines are needed for oral treatment, then we should consult with nephrologists regarding their doses and utilities. And we should consider the bleeding risk assessment, and we should make ready every bleeding management protocols before any surgical procedures. We should consider antibiotic prophylaxis if needed. And nutritional supplementation in malnourished patients should also be considered, and we should work on that also. And it is very important to have a short and long-term follow-up routine in these patients. So after treatment planning, other thing is long-term planning, because this patient should have it is very important for them to maintain their oral hygiene. So regular oral hygiene instructions and reinforcement is needed. Also, as xerostomia is a very common problem in these patients, so xerostomia management protocol has to be revised based on the need of the patient. Also, dietary advice, what are to be restricted according to kidney health and oral health, that advice has to be regularly given. And they should be regularly recalled for oral health examination and treatment if necessary. So the follow-up and maintenance program should usually be 3 to 6 month duration. The other strategy is knowledge and information sharing. Since like we different in specialty practice, we may not be alert of other specialties requirements, so it is always necessary to have regular interdisciplinary case meeting and continuing medical education program between the two faculties for knowledge and information sharing regarding their own disease processes and patient health requirements. Interdisciplinary posting of the residents or bachelor level student in different department may be a very useful tool for knowledge and information sharing. Also, research collaboration, for this evidences gathering in oral renal link is very important. Other strategy is public awareness and research activities, which can be achieved through multi-sectorial approach in research, risk factor navigation and control. Also, we have to promote the oral health promotional activities in different health sectors. Health media campaigning can be very useful. Educating the community health workers and volunteers who are involved in the care of chronic disease patients is very important and useful. Also, it is very important to integrate oral health screening in other associated non-communicable disease like diabetes and cardiovascular diseases. And I have already mentioned the importance of research and further studies to establish to increase the evidences of oral-renal link is also very important. So these strategies can be accomplished, but there can be few challenges ahead. The challenges, important challenges, as been shown by different researches right now, is the first one is low oral health awareness among patients. Studies have found that the renal patient, the chronic kidney disease patients have very low oral health awareness. So it is this can be a challenge. So we have by various mechanisms we have to increase this awareness. The other challenge is poor integration of dental and renal care. So periodontitis is not listed as a complication for chronic kidney disease by current kidney disease improving global outcomes guidelines. And also current guidelines on periodontal disease, they do not require assessing the presence of chronic kidney disease. So it is integration is very important from the policy level. Also, limited screening and treatment resources at various kidney center is one of the major problem. Even though they understand the knowledge, the kidney team, they understand, they have the knowledge of the relationship between oral disease and kidney disease, they are found to be hesitant about oral screening and refer to oral unit because of the limited resources, oral health resources available, or the lack of dental center in nearby. So the future direction will be develop oral screening protocols in renal unit, include dental professional in nephrology teams, research on salivary biomarkers. There are few salivary biomarkers which are being used, but they cannot detect early CKD. So further research is needed. Provide oral health services through every level of healthcare centers so that it will be easy for chronic kidney disease patient to have their regular follow-up. Also, further studies and research in the field should be highlighted. So to conclude, I'd like to say that interdisciplinary collaboration is the need of an hour. It helps in disease prevention, early diagnosis, proper treatment, and holistic care of the patient. And ultimately, it will support the better treatment outcomes for this patient. Thank you. Thank you for kind listening. And if you have any question.
Yes. Thank you, Prof. Asa. Well, I think you need a little drink for you. Yeah. Thank you, Prof. Asa, for your comprehensive presentations. I believe your expertise and your dedication have truly illuminated the path forward in integrated care for kidney patients. And now we have time for around 15 minutes for participants to answer and question and answer time. So I like to ask the participants, I think you can raise your hand or you can write it down. I think there is, okay, Prof. There is one question in the chat room. For patient undergoing, Agnes, can you ask directly? Agnes Lia. Agnes, I think it's better you can directly ask the question. Okay, Prof. For patient undergoing hemodialysis, platelet dysfunction and anemia lead to a bleeding tendency. The recommended dental management is to request a hemostatic study and perform treatment on the day not receiving dialysis. How do dental teams manage solution for emergency oral infection in patients with high bleeding risk, especially if their dialysis schedule cannot be immediately accommodated? Okay, Prof, can you touch the question?
Thank you, Agnes, for that nice question. As far as I understood, you mean to ask like if the patient have higher bleeding risk, how can we manage them, right? Yeah. So it is always better to check their hemostatic bleeding time, coagulation time, etc. before the procedure. And if they require the urgent treatment, like if they require the urgent surgical treatment, first of all, we should, if the bleeding time and coagulation time is really high, then we should go for non-surgical treatment if possible. But if surgical treatment is required, then we should make sure that we have all the measures in our facility, like local hemostatic measures, if that should be available in our settings. And we should also make ready for any emergency bleeding problem that can come in between. That should also be we should be able to handle that by taking the patient to the emergency management center. So we should, first of all, if we have all these things in our setting, then we should go for the surgical treatment. But if we cannot handle the emergency because of the resource problem in our setting, so we should always first of all consider the non-surgical treatment and the medication. Then under the controlled condition only, we should undergo for surgical treatment.
Okay. Yes. Thank you, Prof, for your
Thank you.
answer. Agnes? Okay. The mic is muted in the committee. Okay, Agnes. I think you have already catch the answer, Agnes, yeah? Prof. Asa, there's another
Yes.
question from my college.
Yes.
But he is shy to ask you directly. She chat me.
Yeah, please.
Prof, how to identify oral signs in pediatric patients with kidney disease? So the sign for patient or children patient.
Is that there in the chat box?
No, in my message, but up message, not in the chat box. So she
Okay,
asked about, is there
can you
any
please
specific,
repeat?
is there any specific science for patient with kidney disease, especially for children, children?
Oral signs, you mean?
Yeah, oral signs for children patient.
Yeah, the oral signs for children, for child patient is mainly the there will be similar symptoms like in like I have already discussed, xerostomia related symptoms. But since they are having, if they are having the disease from the development phase of the tooth, so dental problems, the problems related to the teeth are also been visible, like enamel hypoplasia, because they have the problem during the developmental stage of the enamel. So there will be enamel hypoplasia, and also they are at higher risk of dental caries because they have enamel hypoplasia, also xerostomia there. And because if the oral hygiene procedure, oral hygiene protocol is not properly followed, then they will be at higher risk of caries. So rampant caries is one of the sign in these patients.
ECC, early childhood. And also maybe the gingivitis, yeah, Prof.
Yeah.
Yeah. Okay, Putri Wiatini. Yeah, thank you, Putri Wiatini. For you, I've already delivered your question. There's another question,
Thank
Prof,
you.
in the chat room. Hi, Prof.
Okay.
I'm Risma from Risma.
Okay, let me check.
Yeah.
Karishma. Okay. Rishma, your interdisciplinary team.
How is the regular required communication and coordination facilitated in practice? For sharing.
Sharing, yes, that's what I did. I have kept in my slide. So like if you have this integrated system, let me show you with the slide only. So if you have this integrated oral integrated health management system in your country, so it is because individual patient information will be there, so you can always scroll down and like check for the necessary information there. But if it is not there, like in our country, we are still in the developing phase for that, so it's always better to have records, the the information records, either in if it is documented compute what to say
That is wrong.
yeah, if it is okay, so if you can share the electronic records, health records, that will be very beneficial if you have that system in your hospital of the electronic health records of individual patient. That will be helpful to find out these things. And if it is not there, if you have paper system, then you have to do little little bit of more work in that to search for all those datas there.
I see.
Yeah.
Yeah.
So other way is like if you have a renal team and the dental unit in the same building or same compound, it's better to go and consult with the nephrologist at their center itself along with the patient. That will also be helpful.
Okay, Prof. Yeah, I see. In Indonesia, we have also electronic medical record,
Yeah.
especially in hospital. But for primary healthcare,
Okay.
there is no specialist. Can we have a team with medical doctor, Prof? I think
Yeah,
yes. I
of
think
course.
for medical
Yes.
doctor also, okay. Dentist, medical doctor, dental therapist.
Yes.
Okay. Yes, thank you, Prof, for your answer. And then one more question from Triviatini or Putri Triviatini. How is the pathogenesis in children? Is it same or different with adult?
As far as my knowledge, the pathogenesis, you mean the pathogenesis of kidney disease or the oral diseases?
Dental disease and kidney relation between
Yeah,
oral
the relationship between the oral and the kidney diseases. Yeah, I think it's the same, but they are less. The periodontal problem is less in children, so it is mainly related to the oral hygiene habit, I guess.
Yeah, I think yes, agree, Prof. Yeah, Prof. In Nepal, is there any dental therapists work together with you in your hospital?
Yeah, they are not named as dental therapist, but they are named as oral hygienist. Oral hygienist, yeah.
Yeah, oral hygienist. Isn't there any role of the oral hygienist?
Yeah, of course. Like they are the main person. You know, like to like they are the person who take care of the patient oral hygiene on a regular basis. So they can be the first person leading to the diagnosis of the chronic kidney disease as well. Also, they are the person to tackle these problems related to the kidney oral health in related to the kidney health. So dental therapist role is also very important in case of diagnosis as well as the maintenance of oral hygiene in the patient and follow-ups.
Yeah. Because my school here is in dental therapist students, Prof. Okay. Yeah, Prof. Is there any others? I think it's ready for my question, Prof. My last from me.
Yeah, please.
In reference, I have already read about the back and forth relationship between oral disease and diabetes mellitus. But for chronic disease, is there any vice versa or back and forth relationship between chronic disease and oral health or periodontitis especially?
Yeah.
For diabetes mellitus is a lot of many preference about that. Vice versa, back and forward, back and forth. But what about for kidney disease, Prof?
You mean to say the relationship between the diabetes mellitus, the oral health, and the kidney disease?
No. For diabetes mellitus and oral health, it's vice versa, back and forth relationships. So people with diabetes is that periodontitis, but people with periodontitis, they don't have diabetes, but when they have periodontitis and then gotten the diabetes mellitus, so it's vice versa, or back and forth relationship. What about kidney? Is similar?
Yeah, even it is similar in kidney diseases. Yeah, diabetes mellitus and cardiovascular disease, there are a lot of high level of evidences. So it's already a proven thing for diabetes and cardiovascular disease to have a bidirectional relationship with periodontitis. So there are a lot of evidences and proven evidences. So for kidney disease also, they have found that the relationship is like it is a cycle going on there. So they have a bilateral relationship because when you treat the periodontitis, after the treatment of the periodontitis, they have found the improvement in kidney health status. So glomerular filtration rate. So of course, they have found major significance that proves the bidirectional relationship between these two diseases.
Okay, Prof. Yes, thank you.
Thank
And
you.
I'm agree with your future step, yeah, for this about the saliva biomarker, Prof. Yeah, it's
Yes,
for detection, early detection for CKD, Prof.
yes,
Yeah, yes, we can work together, yeah, Prof. Or research together, Prof. Nepal,
yes.
Indonesia next time, yeah, Prof.
Please, please.
Yes.
Yeah, it's always a pleasure. We can work on this because it will become a very nice thing for oral health team as well as kidney team,
Yeah, Prof.
because this will be very easy. No, they don't have to go for, like, they have to go for regular blood test and this thing. So if there is a salivary biomarker, it will be easier for the patient also.
Yeah, I agree, Prof. Okay, Prof. I think it's already 60 minutes for our discussion, Prof. And ladies and gentlemen, we have reached the end of this session. I think I will have a little conclusion about the Prof. Asa presentation. The key takeaway from our discussion is clear. It's about interdisciplinary collaboration. It's not an option, yeah, Prof. It's a necessary, it's a must. And we have confirmed that the significant bidirectional relationship between oral health and renal health, and established that integrated care models involving nephrologists, dentists, hygienists, dental therapists, and nutritionists are essential to truly support the holistic well-being for our patients. Okay, on behalf of the organizing committee, I'm say thank you very much for
Thank
Prof.
you so much.
Dr. Asatepa for your time and also for your comprehensive presentation. It's very nice for us. Thank you very much. I now hands the floor, the Zoom back to the Master of Ceremony for the final agenda. Thank you again, Prof. Good
Thank
health,
you, Prof.
Prof.
Thank you so much.
See you, see you.
See you. Thank you so much.
The signal is not good.
Semarang merupakan ibu kota Provinsi Jawa Tengah. Disinilah tempat berpadunya semangat dan cita-cita untuk menyehatkan bangsa. Poltekkes Kemenkes Semarang berlokasi tepat di jantung kota Semarang, kota pelajar dan pendidikan yang menciptakan iklim pembelajaran dan suasana akademik yang mendukung pencapaian prestasi mahasiswa. Di bawah Kementerian Kesehatan, kami, Poltekkes Kemenkes Semarang, berkomitmen untuk senantiasa berinovasi dalam mempercepat transformasi SDM kesehatan sehingga mampu melahirkan tenaga kesehatan yang unggul dan kompeten. Setiap tahunnya, melalui tahapan seleksi penerimaan mahasiswa baru, Poltekkes Kemenkes Semarang menjadi wadah belajar, berkembang, dan berkontribusi untuk kesehatan bangsa atau Indonesia bagi para calon tenaga kesehatan yang profesional. Poltekkes Kemenkes Semarang memiliki jurusan dan program studi yang beragam yang tersebar di 9 kampus. Kami berkomitmen untuk menghadirkan pendidikan yang bermutu, didukung oleh dosen dan tenaga pendidik yang kompeten di bidangnya. Komitmen bersama ini telah berhasil mengantarkan program studi Poltekkes Kemenkes Semarang menjadi 100% terakreditasi unggul. Poltekkes Kemenkes Semarang memiliki kelas internasional yang memberi peluang bagi lulusannya meraih pekerjaan di luar negeri. Sarana prasarana penunjang kegiatan akademik mahasiswa senantiasa dikembangkan, meliputi laboratorium pada masing-masing jurusan yang dilengkapi dengan alat dan perlengkapan praktikum sesuai kompetensi. Poltekkes Kemenkes Semarang mendukung penuh pengembangan soft skill dan hard skill bagi mahasiswanya. Penyediaan fasilitas sarana dan prasarana telah disiapkan untuk menunjang hal tersebut demi terciptanya mahasiswa yang bertalenta. Layanan perpustakaan Poltekkes Kemenkes Semarang hadir untuk memfasilitasi seluruh civitas akademika dalam mengakses pengetahuan dengan sistem digitalisasi yang modern demi terciptanya individu yang unggul. Sarana olahraga yang tersedia di Poltekkes Kemenkes Semarang menjadi fasilitas demi terciptanya mahasiswa yang prima dalam menimba ilmu pengetahuan di bidang kesehatan dan berprestasi hingga kancah internasional. Poltekkes Kemenkes Semarang menjalin kerjasama yang luas dengan lembaga dalam dan luar negeri untuk berbagai program yang meliputi pertukaran mahasiswa, pertukaran dosen, internship, joint research, community engagement, dan penyelenggaraan konferensi bertaraf internasional. Raih masa depan yang gemilang dengan melangkah bersama Poltekkes Kemenkes Semarang. Unggul, modern, digital.
Dari jantung Kabupaten Pekalongan, hadir Pusat Inovasi Kesehatan Indonesia, Science Technopark Poltekkes Kemenkes Republik Indonesia. Didedikasikan untuk mengubah hasil penelitian menjadi solusi nyata, STP Poltekkes Kemenkes menjadi rumah bagi para inovator dari 38 Poltekkes Kemenkes di seluruh Indonesia. Dengan fasilitas yang modern, ruang produksi higienis, dan sistem keamanan berstandar industri, kami siap menjadi mitra strategis bagi dunia kesehatan dan industri teknologi nasional. STP Poltekkes Kemenkes Republik Indonesia memiliki ruang pameran, ballroom serbaguna dengan kapasitas 200 orang, hingga layanan pengujian X-ray tersertifikasi Bapeten dan jasa sterilisasi ITO. Semua dirancang demi mendukung kualitas, kepercayaan, dan kolaborasi yang kuat. Bersama UPK SDM Kesehatan Semarang, STP Poltekkes Kemenkes menguatkan kompetensi tenaga kesehatan melalui pelatihan berbasis pelataran sehat Kementerian Kesehatan. Science Technopark Poltekkes Kemenkes Republik Indonesia, tempat inovasi tumbuh, kolaborasi berkembang, dan masa depan kesehatan Indonesia dimulai. Informasi lebih lanjut, silakan menghubungi unit pengelola usaha untuk kemitraan dan layanan STP Poltekkes Kemenkes.
heart beats fast, colors and promises. How to be brave, how can I love when I'm afraid to fall? But watching you stand alone, all of my doubt suddenly goes away somehow. One step closer. I have died every day waiting for you. Darling, don't be afraid. I have loved you for 1,000 years. I love you for 1,000 more. Time stands still, beauty in all she is. I will be brave, I will not let anything take away what's standing in front of me. Every breath, every hour has come to this. One step closer. I have died every day waiting for you. Darling, don't be afraid. I have loved you for 1,000 years. I love you for 1,000 more. And all along I believed I would find you. Time has brought your heart to me. I've loved you for 1,000 years. I love you for 1,000 more. One step closer. One step closer. I have died every day waiting for you. Darling, don't be afraid. I have loved you for 1,000 years. I love you for 1,000 more. And all along I believed I'll find you. And time has brought your heart to me. I've loved you for 1,000 years. I love you for 1,000 more. One step closer. One step closer. Loving can hurt. Loving can hurt sometimes, but it's the only thing that I know. When it gets hard, you know it can get hard sometimes. It is the only thing that makes us feel alive. We keep this love in a photograph. We made these memories for ourselves, where our eyes are never closing, hearts are never broken, time's forever frozen still.
So you can keep me inside the pocket of your ripped jeans, holding me closer till our eyes meet. You won't ever be alone. Wait for me to come home.
Loving can heal, your loving can mend your soul, and it's the only thing that I know. I swear it will get easier. Remember that with every piece of you, and it's the only thing we take with us when we die. We keep this love in this photograph. We made these memories for ourselves, where our eyes were never closing, our hearts were never broken, and time's forever frozen still.
So you can keep me inside the pocket of your ripped jeans, holding me closer till our eyes meet. You won't ever be alone. And if you hurt me, well, that's okay, baby. Only words bleed. Inside these pages, you just hold me, and I won't ever let you go. Wait for me to come home.
Wait for me to come home.
Wait for me to come home.
Wait for me to come home. Oh, and you can fit me inside the necklace you got when you were 16, next to your heartbeat where I should be. Keep it deep within your soul. And if you hurt me, that's okay, baby. Only words bleed. Inside these pages, you just hold me, and I won't ever let you go. When I'm away, I will remember how you kissed me under the lamppost back on 6th Street, hearing you whisper through the phone, wait for me to come home. Aren't you something to admire? Cause you shine as something like a mirror, and I can't help but notice you reflect in this heart of mine. If you ever feel alone and the glare makes me hard to find, just know that I'm always parallel on the other side.
Cause with your hand in my hand and a pocket full of soul, I can tell you there's no place we couldn't go. Just put your hand on the glass, I'll be trying to pull you through. You just gotta be strong.
Cause I don't wanna lose you now. I'm looking right at the other half of me. The vacancy that's sat in my heart is a space that now you hold. Show me how to fight for now, and I'll tell you, baby, it was easy coming back into you once I figured doesn't seem really as simple, and I can't help but stare, 'cause I see true summer in your eyes. Ooh, I can't ever change without you. You reflect me, I love that about you. And if I could, I would look at us all the time. Whoa.
'Cause with your hand in my hand and a pocket full of soap, I could tell you there's no place we couldn't go. Just put your hand on the glass, I'll be trying to pull you through. You just gotta be strong.
'Cause I don't wanna lose you now. I'm looking right at the other half of me. The vacancy that's out in my heart is a space, and now you're home. Show me how to fight for now, and I'll tell you, baby, it was easy coming back into you once I figured it out. You're right here all along. Oh, it's like you're my mirror. Oh, my mirror staring back at me. Oh, I couldn't get any bigger. Oh, with anyone else beside of me. Oh, and now it's clear as this promise that we're making two reflections into one. 'Cause it's like you're my mirror. Oh, my mirror staring back at me, staring back at me.
Yesterday is history. Oh, whoa, whoa. And tomorrow's a mystery, mystery. Hey,
I can see you looking back at me. Keep your eyes on me.
yeah. Keep your eyes on me.
'Cause I don't wanna lose you now. I'm looking right at the other half of me. The vacancy that's out in my heart is a space, and now you're home. Show me how to fight for now, and I'll tell you, baby, it was easy coming back into you once I figured it out. You're right here all along. Oh, it's like you're my mirror. Whoa. My mirror staring back at me. Whoa. I couldn't get any bigger. Whoa. With anyone else beside of me. Whoa. And now it's clear as this promise that we're making two reflections into one. 'Cause it's like you're my mirror. Whoa. My mirror staring back at me, staring back at me. Oh.
Show me how to fight for now. 'Cause I don't wanna lose you now.
It's like you're my mirror. What would I do without your smart mouth? Drawing me in and you kicking me out. You've got my head spinning, no kidding. I can't pin you down. What's going on in that beautiful mind? I'm on your magical mystery ride, and I'm so dizzy, don't know what hit me, but I'll be alright. My head's underwater, but I'm breathing fine. You're crazy and I'm out of my mind. 'Cause all of me loves all of you. Love your curves and all your edges, all your perfect imperfections. Give your all to me, I'll give my all to you. You're my end and my beginning. Even when I lose, I'm winning. 'Cause I give you all of me, and you give me all of you. Oh. How many times do I have to tell you? Even when you're crying, you're beautiful too. The world is beating when you're down and I'm around through every mood. You're my downfall, you're my muse, my worst distraction, my rhythm and blues. Can't stop singing, it's ringing in my head for you. My head's underwater, but I'm breathing fine. You're crazy now, out of my mind. 'Cause all of me loves all of you. Love your curves and all your edges, all your perfect imperfections. So give your all to me, I'll give my all to you. You're my end and my beginning. Even when I lose, I'm winning. 'Cause I give you all of me, and you give me all of you. Give me all of you. Cards on the table, we're both showing hearts, risking it although it's hard. 'Cause all of me loves all of you. Love your curves and all your edges, all your perfect imperfections. Give your all to me, I'll give my all to you. You're my end and my beginning. Even when I lose, I'm winning. 'Cause I give you all of me, and you give me all of you, and I give you all of me, and you give me all of you. Oh. Red cups and sweaty bodies everywhere, hands in the air like we don't care. 'Cause we came to have so much fun now. Got somebody here, might be the one now.
If you're not ready to go home, can I get a hell no? 'Cause we're gonna go all night till we see the sunlight, alright.
So la-da-dee-da-dee, we like to party, dancing you and me, doing whatever we want. And this is our house, and this is our rules, and we can't stop, and we won't stop. Can't you see it's we who own the night?
Can't you see it's we who about that life?
And we can't stop, and we won't stop. We run things, things don't run. We
don't take nothing from nobody.
Yeah, yeah.
Homegirls just trying to live it up, shaking it like they can't get enough. Remember, only God can judge us. Forget the haters, 'cause somebody loves you.
Memories made till the night's through, surrounded by the ones who love you. We all so turned up here, getting turned up, yeah.
So la-da-dee-da-dee, we like to party, dancing you and me, doing whatever we want. This is our house, this is our rules,
and we can't stop, and we won't stop. Can't you see it's we who own the night?
Can't you see it's we who about that life?
And we can't stop, do what we want to. It's our house, we can love who we want to.
It's our song, we can sing if we want to. It's my mouth, I can say what I want to.
And we can't stop, and we won't stop.
Can't you see it's we who own the night? Can't you see it's we who about that life?
And we can't stop, and we won't stop. We run things, things don't run. We don't take nothing from nobody. Yeah, yeah. It's our party, we can do what we want to. It's our house, we can love what we want to.
Can't you see it's we who own the night? Can't you see it's we who about that life?
It's our song, we can sing if we want to. It's my mouth, I can say what I want to.
Run things, things don't run. We
'Cause we can't stop. I heard that you're settled down, that you found a boy and you're married now. I heard that your dreams came true. Guess he gave you things I didn't give to you. Oh friend, why are you so shy? Ain't like you to hold back or hide from the light. I hate to turn up out of the blue uninvited, but I couldn't stay away, I couldn't fight it. I hoped you'd see my face and that you'd be reminded that for me it isn't over. Never mind, I'll find someone like you. I wish nothing but the best for you too. Don't forget me, I beg. I remember you said sometimes it lasts in love, but sometimes it hurts instead. Sometimes it lasts in love, but sometimes it hurts instead. You know how the time flies. Only yesterday was the time of our lives. We were born and raised in a summer haze, bound by the surprise of our glory days. I'd hate to turn up out of the blue uninvited, but I couldn't stay away, I couldn't fight it. I'd hoped you'd see my face and that you'd be reminded that for me it isn't over. Never mind, I'll find someone like you. I wish nothing but the best for you too. Don't forget me, I beg. I remember you said sometimes it lasts in love, but sometimes it hurts instead. Sometimes it lasts in love, but sometimes it hurts instead. Nothing compares, no worries or cares, regrets and mistakes, their memories made. Who would have known how bittersweet this would taste? Never mind, I'll find someone like you. I wish nothing but the best for you too. Don't forget me, I beg. I remember you said sometimes it lasts in love, but sometimes it hurts instead. Oh, never mind, I'll find someone like you. I wish nothing but the best for you too. Don't forget me, I beg. I remember you said sometimes it lasts in love, but sometimes it hurts instead. Sometimes it lasts in love, but sometimes it hurts instead. Never mind, I'll find someone like you. When your legs don't work like they used to before, and I can't sweep you off of your feet, will your mouth still remember the taste of my love? Will your eyes still smile from your cheeks? And darling, I will be loving you till we're 70. And baby, my heart could still fall as hard at 23. And I'm thinking about how people fall in love in mysterious ways. Maybe just the touch of a hand. Me, I fall in love with you every single day, and I just wanna tell you I am. So honey, now take me into your loving arms. Kiss me under the light of 1,000 stars. Place your head on my beating heart. I'm thinking out loud that maybe we found love right where we are. When my hair's all gone and my memory fades, and the crowds don't remember my name, when my hands don't play the strings the same way, I know you will still love me the same. 'Cause honey, your soul can never grow, it's evergreen. Baby, your smile's forever in my mind and memory. I'm thinking about how people fall in love in mysterious ways. Maybe it's all part of the plan. I'll just keep on making the same mistakes, hoping that you'll understand. But baby, now take me into your loving arms. Kiss me under the light of 1,000 stars. Place your head on my beating heart. I'm thinking out loud, baby, we found love right where we are. La, 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 so baby, now take me into your loving arms. Kiss me under the light of 1,000 stars. Oh darling, place your head on my beating heart. I'm thinking out loud, maybe we found where we are. I was doing just fine before I met you. I drink too much and that's an issue, but I'm okay. Hey, you tell your friends it was nice to meet them, but I hope I never see them again. I know it breaks your heart. Moved to the city in a broke down car, and 4 years no calls. Now you're looking pretty in a hotel bar, and I can't stop. No, I can't stop. So baby, pull me closer in the backseat of your Rover that I know you can't afford. Bite that tattoo on your shoulder. Pull the sheets right off the corner of that mattress that you stole from your roommate back in Boulder. We ain't ever getting older. We ain't never getting older. We ain't never getting older.
You look as good as the day I met you. I forget just why I left you. I was insane. Stay and play that Blink 182 song that we beat to death in Tucson. Okay.
I know it breaks your heart. Moved to the city in a broke down car, and 4 years no calls. Now you're looking pretty in a hotel bar, and I can't stop. No, I can't stop. So baby, pull me closer in the backseat of your Rover that I know you can't afford. Bite that tattoo on your shoulder. Pull the sheets right off the corner of that mattress that you stole from your roommate back in Boulder. We ain't ever getting older. We ain't ever getting older. We ain't ever getting older. So baby, pull me closer in the backseat of your Rover that I know you can't afford. Bite that tattoo on your shoulder. Pull the sheets right off the corner of the mattress that you stole from your roommate back in Boulder. We ain't ever getting older. No, 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 we ain't ever getting older. We ain't ever getting older. No, we ain't ever getting older. Same bed, but it feels just a little bit bigger now. Our song on the radio, but it don't sound the same. When our friends talk about you, all it does is just tear me down. 'Cause my heart breaks a little when I hear your name. It all just sounds like oh, too young, too dumb to realize
You should have bought me flowers and held
a chance.
Take me to every party, 'cause all I wanted to do was dance.
Now my baby's dancing, but she's dancing with another man.
Your pride, your ego, your needs, and your selfish ways cause a good, strong woman like me to walk out your life. Now you won't never get to clean up the mess you made. Oh, and it haunts me every time I close my eyes. It all just sounds like
Too young, too dumb to realize
that you should have bought me flowers and held my hand.
Should have gave you all my hours when I had the chance.
And take me to every party, 'cause all I wanted to do was dance.
Now my baby's dancing, but she's dancing with another man. Although it hurts, I'll be the first to say that I was wrong.
Oh, I know it's probably much too late to try and apologize for your mistakes. So I just want you to know, I hope he buys me flowers. I hope he holds my hand, gives me all his hours when he has the chance.
Take you to every party, 'cause I remember how much you loved to dance.
Do all the things you should have done when you were my man. Do all the things you should have done when you were my man.
Do all the things I should have done when I was your man. A 100 days have made me older since the last time that I